Hello, welcome everyone. I'm Lena Palaniappan. So today we are going to see a section on study designs. This is QBank Crash Class. This is SPMM course. So in this session, I'm going to cover study types, and I'm going to go into details of case control and cohort studies and how to make 2x2 tables for those studies. I'm also going to take you through calculations for relative risk, odds ratio, attributable risk, which is also called absolute risk reduction or ARR, and I'm also going to show you how to calculate PAR, population attributable risk. These are common calculations that come up in your exams, paper B, MRC Psych exams. Let's start with study designs. Why do we do research? We do research, in clinical sense, we do research to describe a phenomena or analyze the relationship between two or more phenomena, or manipulate one phenomena and see what happens to the other. So these are the three basic types of research studies that you could do. The first issue, describing the status of a population, that is usually done using descriptive studies. Descriptive studies are done to describe the status of a population. What do you mean by status of the population? The status includes issues such as prevalence of a disease, how common is an illness, who are the types of people who get an illness. So it's a description of the nature and distribution of a variable of interest. And in health context, a variable of interest is usually presence or absence of as a pathological condition. So if you take a group of people and measure whether they have a particular diagnosis or not, you're doing a survey. And a survey that is done in a sample of people is called a cross-sectional survey. If you do the same survey for the entire population, you will call that a census study. So a single cross-sectional survey is also called a prevalence survey, because by doing a single cross-sectional survey, that is asking a sample of people a specific question on a particular condition, you could understand the prevalence of the condition. In other words, you can find out how common is a problem by doing a single cross-sectional survey. For this reason, we call a single cross-sectional survey as prevalence survey. You can also find incidence by using a cross-sectional study, but you have to do the cross-sectional study 2 times in the same population with a reasonable time period in between. For example, if I want to find out how many people have myopia in a town, I have to study the number of myopics in the town today in 2017, and then I have to study the same sample of people in the same town in another point of time, that is after 1 year. Now, between these two cross-sectional studies, if there are new cases of myopia that is emerging, then I will have more numbers during my second study compared to my first study. So this will give me an indication of incidence. So in order to do incidence, you need to do, in order to calculate incidence, you have to do 2 cross-sectional surveys. So this is about descriptive studies. Then comes analytical studies. The term analytical tells you what these studies do. They analyze the relationship between 2 or more factors. You can do analytical studies in 3 forms. You can either do cohort studies or case control studies or ecological studies. I will tell you in more detail about each of these studies as we go along. The third large type of study design that we can think of is experimental studies. What is an experimental study? In an experimental study, you actively manipulate or change one factor and analyze the relationship that that factor has with another factor. For example, you manipulate treatment and you see the treatment response. So in other words, it is very similar to analytical study in that you are seeking a relationship between 2 variables, but in analytical study, you do not actively manipulate any of these variables. But in an experimental study, you manipulate the treatment and you watch the effect. There are 2 types of experimental trials: controlled trials and uncontrolled trials. Commonly, we talk about randomized controlled trials or RCTs. These are controlled trials. You can also do an uncontrolled trial, and that will also be an experimental study design. So these are the 3 major types of classifications in study designs. Let's start with looking at more details about analytical studies. I showed you 3 types of analytical studies: case control, cohort, and ecological. Let me explain those three types using an example. Let's say I am interested in two variables. I want to find out the relationship between eating chocolates and committing suicide. I have a silly hypothesis. I think if you eat a lot of chocolate, it's likely that you will self-harm or you will kill yourself. I want to test this silly hypothesis. And what are the three ways in which I can test? Number one, I can select a cohort of people exposed to too much chocolates and a cohort of people who had never seen a chocolate in their life, and I can follow them up and see how many of them kill themselves. And if there is a difference between the two groups, then I can say there is a relationship between eating chocolates and committing suicide. What kind of study is this? This is a cohort study. I can also do a different type of study. I can ask from the family members of people who committed suicide. I can ask them how much chocolate the person who committed suicide was exposed to. And I can compare this to number of chocolates consumed by a non-suicidal control group. For example, people dying of the road traffic accidents, and I can find out how many of them consumed, how much chocolate they consumed before they died. So this will establish some relationship between suicides and consumption of chocolate. What kind of design is this? I start from a case. A case is a person who committed suicide, and control is a person who has died by other means, who hasn't committed suicide. So if I compare a case and a control in terms of the exposure that happened in the past, this is called a case control study. Thirdly, I can also compare suicide rates in high chocolate consuming countries and low chocolate consuming communities. Let's say we have out of several European countries, let's say we have 4 or 5 countries which consume more per capita chocolate than other countries. I can look at the suicide rates in these countries and see if there is any trend relating suicide rates with heavy chocolate consumption. So what kind of study I am doing here? I am doing something called ecological study. Now, ecological study is not always classified as an analytical study because some people object to this. Why is that? In an ecological study, you are not interviewing individual subjects. Okay, so you're not making any inferences on individuals. You're only observing groups, countries, and you're taking two different values from those countries and see if they are related to each other. So if you try and make an association at an individual level on the basis of an observation that is made at a group level, you're committing an error, and this error is called ecological fallacy. For example, in this situation, if you have high chocolate consuming countries showing high suicide rates, you cannot say it is the people who ate a lot of chocolates are the people who kill themselves, because we haven't established that kind of individual relationship. If you make that kind of conclusion, then you are making an error, and that's called ecological fallacy. Okay, now let's see what are the differences between case control and cohort studies. A case control study is cheaper to do. It's almost always retrospective. Both exposure and disease has already taken place. And it's more prone to recall bias, even though it's quicker to complete. But a cohort study is quite costly because you need to factor in the amount of time that you have to follow up people, and it's almost, in most cases, it's prospective. But remember, you can also do a retrospective cohort study. Whenever we just say cohort study, we mean a prospective cohort, but retrospective cohort is also feasible. Exposure has happened and the outcome has not yet happened in a prospective cohort study. A prospective cohort study is less prone to bias, such as recall bias, because you are not estimating exposure based on people's recall. You are estimating exposure, you're measuring exposure right at the beginning. You're not depending on recall. Cohort study is more prolonged, more time consuming. Okay, but each of these two studies, case control and cohort, have their own specific usage. What is that? If you are studying a rare disease such as schizophrenia, any disease which has rare or less frequent outcomes, any event, any phenomena that has a infrequent occurrence, you can study that phenomena using a case control design in a much better fashion compared to a cohort study. Imagine the relationship between obstetric complications and schizophrenia. How many people with, how many mothers with obstetric complication do you have to follow up in order to find one case of schizophrenia, you may have to follow up thousands of mothers with obstetric complications, children born to them, in order to see if any of them develop schizophrenia. Because the outcome schizophrenia itself is quite rare, even though the exposure obstetric complications is much common. The corollary is true for cohort study. If you are studying a rare exposure, then a cohort study is much more useful. For example, if you want to estimate the relationship between PTSD and nuclear accidents such as Chernobyl, it's better to do a cohort study. So you can follow up a cohort of people exposed to Chernobyl disaster and a group of people who are exposed to different type of trauma, and you can follow them up and see how many of them develop PTSD. But if you want to sample, if you start with a sample of people with PTSD and then try to find out if that sample has any relationship with Chernobyl disaster, it'll be very hard to establish that, because the exposure is quite rare. You may have to assemble 100,000 PTSD patients in a room to get at least one who was exposed to the Chernobyl or any other nuclear disaster. So the bottom line is, if you have a rare outcome, use a case control study. If you have a rare exposure, use a cohort study. Okay, now we have a 2x2 table for case control study. How do we do a 2x2 table for a case control study? Please try to follow the same style that I use. In the first column, I always write exposure present, exposure absent. And on the top row, I write cases and controls. In other words, disease present, disease absent. Okay, so exposure present, exposure absent in the first column, disease present and absent in the first row. And then you can fill in A, B, C, D, so on and so forth. Always add a third column. Even though you call this as 2x2 table, please have a third column and a third row where you put the total values. Okay, so this is a 2x2 table case control study. In a 2x2 table for a case control study, the final product you get, it's called odds ratio. So we draw a 2x2 table for a case control study in order to extract the odds ratio, OR. Okay. In a cohort study, the final products are different. We derive risk values in a cohort study. What is risk? Risk is the probability of something occurring in the future. Okay, so only in a study which follows up people into the future, you can understand the risk values. So you need a cohort design in order to estimate risk. With a cross-sectional design such as a case control study, you can only get an odds ratio, you cannot get a relative risk. Okay, so this is question time. Okay, this is question time. Let's start with the first question in Study Designs chapter. An environmental agency identifies 200 patients with lifetime history of panic attacks and 200 matched controls without the condition. Exposure to loud traffic noises was compared in the two groups. 20 patients and 10 controls had such an exposure. What type of study has been described here? Nested case control study, cross-sectional study, retrospective cohort study, prospective cohort study, case control study. So in this study, they are taking 200 people with panic attacks, which are cases, and 200 people who are matched controls. So that's where the study starts, case group, control group. And then they ask them how many of them had an exposure. The exposure here is loud traffic noise. So as this study starts from a case and a control and then traces back to see what the exposure is, this is a case control study. E is the right answer. In the above study, the case exposure rate 20 by 200, 10 by 200, 20 by 100, 20 by 30, 10 by 30. How do you calculate case exposure rate? We have to draw a 2x2 table. We have to draw a 2x2 table to extract the case exposure rate and also other calculations. Let's first start with the values that we have in the study. We have 200 people with panic disorder and 200 people with no panic disorder. Now we know out of this 200 with panic disorder, 20 have the exposure. And out of this 200, we have 10 with the exposure. So we put those values in these boxes and then we fill the rest of the missing values by subtracting the total numbers, and we are getting 20, 10, 30, 180, 190, 370, 200, 200 and 400 here. So the case exposure rate is now How many people are cases? Everybody with panic disorder is a case. So the exposure rate is 20 by 200. Out of 200 cases, 20 are exposed. What about control exposure rate? These are people without panic disorder, 200 of them. How many of them are exposed? Only 10. So 10 by 200 is the control exposure rate. So in the above study, the case exposure rate is 20 by 200. In the above study, the odds ratio of being exposed to loud noise in those who have panic attacks compared to those who do not have panic attacks is, what is the odds ratio? 20 multiplied by 190 divided by 10 multiplied by 180. Odds ratio is a cross product ratio. So you multiply 20 with 190 and you divide that by 10 into 180. So whenever somebody asks you to calculate odds ratio, just put an X on the table, X. Okay, 20 into 190 divided by 10 multiplied by 180. So this is the value, 20 into 190, 10 into 180. Now that choice is given as choice E, 20 into 190 divided by 10 into 180. That's the odds ratio for this 2 by 2 table. Which of the following information cannot be calculated from the above? Case exposure rate, control exposure rate, odds ratio, relative risk, none of the above. We have just calculated case exposure, control exposure, odds ratio. We cannot calculate relative risk because this is a case control study and this is not a study where risk is meaningful. We can only calculate odds ratio from a case control study. Okay, now we are moving into the study of confounders. What is a confounder? A confounder is a third factor. It is neither the exposure nor the outcome, but a third factor. The third factor, which is associated with both exposure and outcome, it modifies the outcome, but it is not on the causal pathway. Do you remember how I said analytical studies focus on studying the relationship between two variables, one being the cause, the other being the effect? Okay, but a confounder is a factor that is neither the cause nor the effect. It stays somewhere in between. It is related to both the cause and the effect, but it is not on the causal pathway. For example, the question that we just saw, we are assuming that loud noise is the exposure and panic disorder is the outcome. Okay, now people who are exposed to more noise are getting panic disorder, but could that be because of a third factor such as socioeconomic status? People who are poor, living in relative poverty, are going to live in urban areas where there is higher loud noise, higher exposure to loud noise, and they're going to also have high amount of panic disorder. So this panic disorder has nothing to do with the loud noise. It is something to do with the socioeconomic status. If that is true, then socioeconomic status becomes a confounder because it is related both to the loud noise and the panic disorder, but it is not on the causal pathway. Loud noise does not cause panic disorder through socioeconomic status, through manipulating socioeconomic status. Okay, so this is a confounder. It's a socioeconomic status is related to panic disorder on its own. It's a confounder. A confounder is troublesome only if it is unequally distributed between the two groups. Okay, alcohol, smoking, gastric cancer. This is another example of confounder. Alcohol can increase risk of gastric cancer, but it could do so because alcohol is associated with increased smoking. People who drink a lot also smoke a lot. It could be that smoking relates to gastric cancer, not alcohol. In that case, smoking becomes a confounding factor because it appears as if alcohol increases risk of gastric cancer, but in fact it is mediated or confounded by the increased amount of smoking that you see among alcoholics. This is another example of confounders. How do you deal with confounders? I already mentioned randomization. So you can randomize and allocate people into two groups, pick them randomly from a sample. By doing randomization, you are allowing the nature to equally distribute the variable that can confound between the two groups. There's no guarantee that this will happen, but you can rest assured that you can relax a bit that randomization will look after the distribution of the confounder. In fact, randomization can look after the distribution of both known confounders and unknown confounders. Even if you don't know if something is a confounder or not, by randomly picking the two samples from the same population, you can make sure that they are equally distributed. Well, you can increase the chances that they are equally distributed. So apart from randomization, you can also control for confounders using various other means. What are they? You can do restriction, you can do matching, you can do minimization. Restriction is not allowing the confounder to be a part of the recruitment. So anybody who is a smoker, don't come to my study, because I'm studying the relationship between alcohol and gastric cancer. I'm comparing alcoholics and non-alcoholics. I do not want to take anybody who is a smoker into my study. I just completely avoid them. By restricting smokers, I am eliminating the effect of that confounder. I can also do matching. For every smoker who is an alcoholic, I can find a smoker who is a non-alcoholic, and then I can compare the two groups for the risk of gastric cancer. So in this way I am matching. Do you remember I mentioned that if confounder is equally distributed, it won't give any trouble? That's why we do matching. We match so that confounder is equally distributed between the two groups, so we don't have to worry about it anymore. Minimization is a method that's in between matching and randomization. You pick first person randomly, but every other person that you recruit for the study will be based on matching over various different number of confounders. When do we do minimization? We do minimization if we have a small sample not adequate for randomization, but we have multiple confounding factors, not possible to do matching. Okay, so minimization is done when you have small sample but multiple confounding factors. So all of these steps, restriction, matching, minimization, randomization, they could be done at the stage of recruitment. If you, let's say you have a study that you have started recruiting, you didn't know about a confounder, but now it comes to play in your mind. What can you do? You can control for confounders at the stage of analysis. You can adjust the analysis. You can do adjustment, statistical adjustment by stratification. You can stratify people into a single group of patients. You can stratify them into people who are exposed to the confounders, people who are not exposed to confounders, and you can study what is the relationship between the variable of interest, the exposure and outcome in each of the groups separately. That's called adjustment, and then you can adjust for the stratified value. You can also use multivariate statistical methods, and you can use things such as multiple regression, and there are many other multivariate statistical methods, ANCOVA. You can use those methods for controlling for confounders. Now let's move on to some questions. Which of the following is not a suitable method to reduce confounders in a study before the data is collected? Can you do randomization? Yes. Restriction? Yes. Stratification? Yes. Minimization? Yes. Regression? No. Regression, multiple regression, is a statistical procedure. You can do it only after you collect the data. Let's now move on to cohort study. When you have a 2x2 table for a cohort study, it looks like this. I use the same principle as a case control study. Disease present, disease absent. Goes on the first row. The first column, exposure present, no exposure. That goes on the first row. Okay, same kind of nomenclature, A, B, C, and D, and you have 3 columns and 3 rows in order to show the total values. Now, whenever you have a 2x2 table for a cohort study, you can do much more than odds ratio. In a case control study, all we managed to do was only an odds ratio. But in a cohort study, you can do the odds ratio if you want. You can also do something more. So what is that something more? You can calculate, number 1, absolute risk of the incidence in each group. What is absolute risk in the exposed group? Who are the number of people who are exposed? A plus B. What is the risk of the disease in A plus B group? A. A over A plus B is the absolute risk in the exposed group. What is the absolute risk in the non-exposed group? C over C plus D. So you have now 2 absolute risk values. Okay. What happens if you subtract one value from the other? You get attributable risk. Attributable risk is the subtraction of one absolute risk from the other. So absolute risk will be high in the exposed group, because if exposure causes the disease, you will have more disease in the exposed group. Okay. So take A by A plus B, subtract it. Subtract C over C plus D from A over A plus B. If you do that, you're getting attributable risk. This is also called absolute risk reduction, because what you did now, you took 2 absolute risks, you reduced one from the other. Okay, so ARR, also called attributable risk, is nothing but risk difference, subtraction of 2 absolute risks. If you want to do a ratio of these 2 risks, if you don't want to subtract, you can do a ratio. If you do a ratio, you have absolute risk in the exposed group on the top divided by absolute risk in the non-exposed group on the bottom. This ratio is called relative risk. Okay, so the next risk term that we have is population attributable risk, PAR. This is also called the risk daddy. This is a very important risk value when it comes to public health and epidemiology. What is PAR? PAR stands for the number of cases that you could eliminate from the entire population if you completely remove the exposure from the population. So if somebody asks you how many cases of lung cancer can you prevent by completely stopping a population from having access to cigarette smoking, that number can be given by PAR. So to calculate the number, you need two things. One, you need ARR, attributable risk reduction, attributable risk ratio, number, risk difference, ARR, absolute risk reduction or attributable risk, and you multiply that ARR by proportion of the population that is exposed to the risk factor that you are interested in. So in this case, you will multiply that by the proportion of population that is smoking. If you want to calculate the amount of lung cancer that can be eliminated by removing smoking, you just multiply the ARR for smoking in a cohort study and multiply that by proportion of population that is smoking. Okay, so now we have a question. Among 100 smokers followed up till death, 35 develop cognitive impairment. Among 100 non-smokers followed up till death, only 15 develop cognitive impairment. What is the risk value attributable to smoking in the study? So several answers are given: 35 by 100, 15 by 100, 20 by 100, 35 by 15, 35 multiplied by 15 divided by 100. How do you calculate this? So we need to draw a 2 by 2 table. I have done a 2 by 2 table for you in the slide. So you can see I have put smoking and no smoking in the first column, and I have written disease positive and disease negative. That is cognitive impairment positive and cognitive impairment negative, absence of cognitive impairment, in the two rows, top rows. In the top row I've written this. So the column here has totally there are 3 by 3 rows and 3 columns. I'm including the total column and the total row as well. So we know that there are totally 35 cases of cognitive impairment among smokers, and we know there are 100 smokers, and we know there are 15 cases of cognitive impairment among non-smokers, and we know that there are 100 non-smokers from the question. So we can fill the rest of the gaps, 65, 85, and add these two, this will become 50, add these two, that will become 150, add these two, that becomes 200. So now what is the absolute risk in the exposed group? Who is the exposed group? Smokers. How many are exposed? 100. How many are becoming unwell, becoming cognitively impaired? 35. So 35 by 100 is the absolute risk in the exposed group. Same way, the absolute risk in the non-exposed group will be 15 by 100. Now you have two absolute risks, don't you? Can you subtract them? Yes. If you subtract them, you will get ARR. 35 by 100 minus 15 by 100. That gives you 20 by 100. That's the ARR, absolute risk reduction, simply called risk difference. You can also call that attributable risk. Okay. So the answer for this question: among 100 smokers, 35 have cognitive impairment. Among 100 non-smokers, only 15 have cognitive impairment. What is the risk value attributable to smoking? 20 by 100. Okay, so the answer is C, 20 by 100. Next question: using the above information, if 25% of UK population are smokers, then the proportion of those with cognitive impairment attributable to smoking is 1 by 20, 1 by 4, 3 by 4, 3 by 20, 1 by 33. Okay, so we need to calculate PAR. Now we know what PAR is. PAR is given by number of cases that could be eliminated by stopping smoking in the whole population. So ARR multiplied by proportion of population that's exposed. 20 by 100 multiplied by 25 by 100, and you will get 1 by 20. So that's the correct answer for PAR. You know 25% is the value given. 25 by 100 is the proportion of smokers. You multiply that by the ARR you calculated in the previous question, which is 20 by 100, and you get 1 by 20 as the right answer for this question. Okay, did you all get that? Good. Okay, let's move on. Before we move on to randomized control trials, I want to show you some information about causality. There are different criteria for determining causality. These were initially put forward by an epidemiologist called Bradford Hill. According to Bradford Hill, if you want to say A causes B, then A should precede B. So this is called temporal association. A must happen before B happens. This is temporal association. Higher the dose of A, higher the intensity of B should be. So the more the cannabis somebody smokes, the more psychotic should they become. That's called dose-response relationship. That's also necessary too. That's also important. None of them is necessary or sufficient, but these are all important features of um, causal argument. Specificity. If A causes B, then nothing else should cause B. A must be specific to B and B must be specifically caused by A. Now, this kind of specificity often fails in multifactorial disorders like diabetes, like schizophrenia, depression, and all other psychiatric disorders. So, we can't often hold specificity argument for most causal arguments. Consistency. Every time you see A, you should see B as well. If that's present, then you can say A causes B. There must be some plausible biological association that you should be able to draw between A and B. Now, if you say cannabis causes psychosis, you may be able to show a brain pathway, a network, or a mechanism. For example, cannabis somehow manipulates the amount of dopamine in the brain, and that somehow relates to some reward pathway abnormalities, and that causes psychosis. That kind of plausible biological association could be only if that plausible biological association could be drawn. You could say A causes B. If you cannot draw any associations, you cannot make a causal argument. High strength of association. So whenever you see an effect size relating A and B, that effect size must be very high. Small effect sizes are not that causally conclusive. So you should have high effect sizes of association. Absence of reverse causality. If A causes B, then B should not be causing A. If B causes A, then you can't say A causes B. For example, cannabis, if you want to say cannabis is a risk factor for psychosis, then smoking cannabis must be causing psychosis, not the other way around. Not, if a lot of people who become psychotic, who never smoked cannabis before, if they then take up cannabis after they become psychotic, then the argument of reverse causality comes into play, and you cannot really say cannabis is the cause of psychosis using epidemiological models. Okay, so these are some of the criteria that has to be satisfied. None of these criteria, none of the individual criterion is necessary. None of them are sufficient as well. So you need to know these criteria as indicators of causality. Okay, so now let's move on to the next session, randomized controlled trials. So this is an anatomy, this is a structure, a little flow chart of how a randomized controlled trial is conducted. The first step in doing a randomized controlled trial is generating a sequence of random numbers. So you have to generate a sequence of random numbers. And let's say if you want to randomize 100 people, and if you want to take them into two groups, 50 receiving treatment and 50 receiving placebo, then you should have 100 random numbers generated. A sequence of 100 numbers, and some of them should be allocated A, some of them should be B, and that list should be prepared even before you start recruiting patients. So generation of random sequence is the first step. And then what you do, you have to keep that sequence quite secret. You should not let anybody know. Anybody in the trial should not come to know about the sequence that you have generated. Why? If they come to know, then they may influence at what time point each individual is recruited into the study. So they may introduce some selection bias if they come to know what is the treatment that every number is going to receive. So let's say number 5 is allocated to treatment A, and you know treatment A is placebo. And if one of your clinicians who is recruiting for the study comes to know that, then that clinician may say to his patient, well, wait for another 1 month. If you go into the trial now, the chances of you getting the active treatment is low. So he may influence, unknowingly or unknowingly, they may influence who gets the treatment and who gets the placebo. So the random sequence must be really kept secret. Okay, so this is called allocation concealment. Keeping the random sequence secret from the investigator, clinician, and the patient until the assignment is completed. I'll tell you more about the allocation concealment in the next few slides. So that's the first step, generation of the sequence and concealing the allocation. The second step is assigning the treatment. So a patient comes in, he or she has volunteered to be on the RCT. You send the patient to the person who keeps the random sequence, and that person checks this patient's number. So let's say this is the 7th patient enrolled in the trial. The person who keeps the generated sequence checks the number 7 against A, whether they are falling against A or B, and depending on that they will assign this person to either treatment A or treatment B. Treatment A could be placebo, treatment B could be the standard treatment. Okay, so that the process of giving the treatment to the patient is called assignment. And then the treatment starts. most RCTs run for a fairly limited period of time, 6 weeks to 3 months or so. So for that time, when the patient is taking the treatment, it's important to keep the patient on the same treatment, if that's the protocol. So keep the patient to stick to the protocol, maintain the treatment. And when after the assignment as well, you should make sure the patient and the clinician who is treating the patient do not come to know what treatment the patient is getting. So this is called double blinding. Well, blinding stands for keeping the allocation secret from the investigator after, or the patient or the clinician, until you measure the final outcome. Okay, so after assignment, after patient starts taking the treatment, make sure that nobody knows what treatment patient is on, whether he or she is on placebo or whether he or she is on active treatment. That fact should not be known to anybody apart from the person. Well, it should not be known to anybody at all involved in the trial. Okay, so if you manage to do that, keep that secrecy, that's called blinding. Okay, and how long do you keep that secret? Until you measure the final outcome. The final outcome could be measured after 6 weeks or 3 months according to your protocol. And after you measure the final outcome, you can unblind the patient and you can tell them, what treatment they're taking. Sometimes trials continue for a period of time after the blinding is undone. That's called open label phase. Okay, so I'm not showing you the open label phase in this chart. So these are the different aspects of a randomized control trial. To just help you remember the sequence, I have given a mnemonic GAME. G is generation of random sequence, A is assignment, M is maintenance, E is examination or evaluation of the final outcome. E is the evaluation of final outcome. So GAME, G-A-M-E, between the G phase and A phase, you have allocation concealment, and from maintenance up to the evaluation phase, you do blinding. So how do you do randomization? I said that you have to generate a random sequence. How can you do that? You can simply put 100 numbers in an Excel sheet in a computer, and you can click the random function on the Excel sheet, and the numbers will get randomly aligned. So you can then pick the first 50 numbers to go to A and the next 50 numbers to go to treatment B. So that's a very simple random procedure. In simple randomization, you take the final sample size and you randomize all of the sample in one go. So if you want to take 100 people in your study, you take those numbers 100 and you randomize all the 100 in one go. The problem with doing simple randomization is, let's imagine number 1, number 2, number 3, number 4, all 4 of them, by random chance, let's say all 4 of them are falling into the same group, group B. Group B is active treatment, okay? Group A is the placebo. You are randomizing, and due to random nature, random means you're not controlling it. It can just go either way. By chance, you're getting first 4 people going on the same treatment. In this study, then, the study has to stop at some stage. Let's say a simple random study has to stop midway. If it stops midway, then you might end up having more people in one arm than the other arm. Let's say if you're stopping the study after 6 recruits, you will end up with 4 people in the active treatment arm and only 2 people in the placebo arm. So that kind of differences could get exaggerated if you're doing a simple random allocation, simple random sequence generation. So it's all and good if you can continue the study and complete it as you plan, but if you have to stop the study in the middle, then simple randomization is a problem. You have to do something else, block randomization. In block randomization, we don't take all the 100 numbers and randomize them in one go. Instead, we take only 4 numbers at a time or 6 numbers at a time and randomize only those into A or B. So the first 6 people will be randomly allocated to either A or B, and then the next 6 are dealt with, and then the next 6 are dealt with. So this way, you are taking only one block at a time. Even if you have to stop the study at a given after a particular time point, you will have more or less same number of people in both groups. So that's the main reason we do block randomization. Okay. So this is a picture of simple randomization. So you see, I want to randomize 9 subjects, and I have now subjects from 1 to 9, and I take all of them in one go and use a computer sequence and randomly allocate them to either A or B. So can you see now A, and next 4 are allocated to B, and then 2 A's here and 2 B's here. So that could end up as a problem. So what I do here in a block randomization, I take only 4 people at a time, 1, 2, 3, 4, and I allocate them into either A or B. So in this case, if first one goes to A, second one goes to B, third goes to A, fourth goes to B. ABAB is the first sequence, ABBA is the second sequence, AABB is the third sequence, and so on and so forth. Okay, so this will ensure that even if I stop the study, let's say if I stop the study at this point, until at this point I would have more or less equal number of A's and B's. So I will be able to do a meaningful analysis even in the interim, or even if the study stops the midway. A study could stop for various reasons. People run out of funding, or the investigators, for some reason, well, the investigator dies, or something like that. Serious things happen, could end a study. Or if there is an adverse event that takes place that you have to stop the study for, all of these things could make a study stop midway. And if you do that, then that will indicate to you that well, that in that case, if you stop the study, block randomization will help you much better than a simple randomization. What is the problem with block randomization? Can you see that if you put first person into A, second into B, third into A, there's only one place the fourth person can go, and that's B. Same way, if you put A, B, B, there's only one place the fourth person can go, and that's A. So in a block randomization, every nth person, if it is n number of blocks that you randomize, 5 people in a block, 4 people in a block, then the last person can always be predicted. Okay, this is somewhat counterintuitive to what you want to do in an RCT. You want to conceal everything here, but with a block randomization, there is a bit of a leakage here. People could predict where the fourth person or the fifth, sixth person can go. So this is a problem, but nevertheless, it's useful when you deal with studies where you may have to conclude the study in the midway. In studies where equal number is important in both arms. Okay, so we talked about simple randomization and block randomization. What other methods of randomization do we have? We have cluster randomization. Cluster randomization is usually done in big multi-center trials. So instead of randomizing individual people, let's say you want to recruit 100 people. Instead of randomly choosing 100 people, what you do, you randomly pick big geographical or ecological clusters to which the patients belong. Let's say a general practice catchment, or a primary care registry, or a county or a city. So you take those big geographical or ecological systems to which people belong, and you randomize those systems, and you randomly pick one or two of those systems. And once you randomly pick them, these systems are called clusters. Once you randomly pick a cluster, you ask everybody in the cluster to be enrolled in your study. So this is called cluster randomization. So a good example is if you want to recruit, let's say if you want to recruit 10 psychiatrists to participate in a survey, if you take a registry from Royal College of Psychiatrists, there are more than, well, I don't know, 20,000 psychiatrists in the country, and if we randomize them and pick 10 people randomly, one might be in Inverness, one might be in Brighton, one might be somewhere in Isle of Man. So it will be very difficult for me to track all these psychiatrists down and do a survey. So instead I could randomly pick a county. We have a finite number of counties in England and Scotland, so we can pick random, or Ireland, and we can pick a random number of counties. Let's say we pick 2 counties. I managed to pick Nottinghamshire and let's say Northamptonshire, and I will just only include all the psychiatrists that are in these 2 counties. Okay, I'll get the numbers that I want, but I will not be randomizing every psychiatrist. I'll only randomize the clusters to which they belong to. So this is called cluster randomization. Okay, and this limits the power of your analysis because you're picking only less number of units, like only 2 units are picked up in the example I gave. Even though you have enough sample to do the analysis, the power itself will be reduced because your random picking is restricted to small number of units. Okay, so this is cluster randomization. It's often used in large epidemiological studies, multi-center trials. What is stratified randomization? So if you're worried about some factor affecting the randomness of the 2 groups, for example, you're worried about gender distribution being different between the 2 groups of treatments, treatment A and treatment B, you can first of all randomly pick 100 people. First of all you can ask for 100 patients to be volunteers, and then you divide patients into 2, males and females, and you randomly pick 50 males and randomly pick 50 females. So you do random picking 2 times, but in 2 different layers, 2 different strata, one being male, one being female. So this is called stratified random sampling. When you do stratified randomization, you will make sure that a factor that you're worried about, a confounding factor, is equally distributed in the two groups. So if you're worried about gender being some kind of influence on treatment response, by making sure you're picking 50 males and 50 females, you are making sure that both of them have equal chance of getting into the trial and both of them have equal chance of going to either arm A or arm B. So this is called stratified random sampling. What is quasi-randomization? The word quasi means false or pseudo or inadequate. Quasi-randomization includes methods such as getting people out through their birth dates. Anybody who has an even number of birth date, if you're born on 14th of September, for example, you will go into group A. If you are born on an odd date of birth, like 13 or 11, then you will go into treatment B. So which treatment arm you go to depends on whether you have an odd number or even number of date of birth. Now this might sound completely random because nobody has a control over when somebody is born, right? But it's not about just control, it's about predictability. If you have a method like this, then people can actually easily predict which arm a particular patient might go to. That's going to defeat the whole purpose of your randomization. It's going to introduce bias. So we don't use these methods commonly. If somebody is using them, this should be properly termed as quasi-randomization. Okay. Now remember, coin toss is not quasi-randomization. If you're tossing a coin to decide heads or tails and decide which arm somebody goes to based on what they get in a coin toss. So if you have a patient, let's say 7th patient, you toss a coin and 7th patient has heads, and if it heads, he goes to treatment A. If it's tails, he goes to treatment B. If you make a decision like that based on coin toss, yes, it is something like simple randomization. It's not a bad method compared to quasi-randomization, but nevertheless, it's not an adequate method because it's not just about concealment. It's also about reproducibility. So if somebody wants to try to do the same thing, there should be a reasonable degree of reproducibility. With only 2 options available in a coin toss, you don't get a good degree of reproducibility. So we don't prefer this coin toss method, and instead you will prefer a simple computer generated randomization method or a block randomization method. And if there is a necessity to do cluster because of geographical constraints and resource constraints, you can do cluster randomization. And if you are worried about confounders, you can do stratified randomization. So those are some of the methods of random sampling. Now let's go to a little bit more details about allocation concealment. So what is allocation concealment? After the sequence is generated, you make sure that nobody comes to know about the sequence, preserving the outcome of randomization. Now, why do we do that? This will help us to reduce selection bias. This will help us to maintain the integrity of randomization. How can we do this? Well, make sure that different persons are generating the allocation sequence and determining the eligibility and the entry of patients. So whoever is doing screening should not be doing generation of random sequence. Okay, so you separate the people involved in the trial. Number 2, use people not involved in the trial for the mechanism of treatment allocation. So use a central telephone randomization system or use a pharmacist to allocate people to treatment. And the pharmacist will keep the random sequence safe. You can enclose sequences in a serially numbered, opaque, sealed envelopes. This is called snooze procedure, serially numbered, opaque, sealed envelope. A snooze procedure will make sure that nobody can break the confidentiality or the secrecy of your allocation. So these are the different methods you can use to conceal allocation. What about blinding? Blinding is maintaining the secrecy once the allocation is complete. So this is something that starts after the treatment is assigned. Now you can have a single blind trial where only the patient or the researcher is blind to the allocation. Or you can have a double blind trial where both the patient and the researching investigator, the clinical investigator, is also blind to the treatment. What about triple blind? You have the patient blind, the clinical investigator blind, and also the analyst, data analyst. He or she is also blind to the allocation. Finally, you can have an open label phase or open label trial where nobody is blind. Everyone knows what the treatment is, what kind of treatment is going on. Okay, so these are the different types of blinding. Could you make sure blinding works? How can you make sure blinding works? So in the middle of the study, just stop the study for a while and check with every patient what medication do they think they are taking. Are they on placebo or are they on active treatment? Ask them to make an educated guess. If you have more than 50% people guessing correctly, then there is some problem with your blinding procedure. Somehow people are coming to know what they are taking. Why do we do blinding? Blinding is done to reduce measurement bias. Remember, allocation concealment is done to reduce selection bias. Blinding is done to reduce measurement bias. Okay, so this is a table with differences between allocation concealment and blinding. Both are important. Allocation concealment can always be done because once you have a random sequence, you can always conceal its allocation. You don't need to follow any complex procedures to do this. And in every situation where you do an RCT, you are able to do allocation concealment. Blinding may not be always possible. Okay, imagine a situation where you are evaluating CBT versus mindfulness. When you're doing those kind of treatments, people will come to know what they're going through. So there's no way you can completely keep people blind for certain types of trials, psychotherapy trials, surgical trials. It's hard to keep people completely blind. Okay, let's now see some questions. First question. A researcher wants to make sure that the size of the control and two intervention groups are more or less equal so that statistical deductions can be meaningful. Which of the following methods of randomization could ensure this? Block, cluster, stratified, simple, quasi-randomization. We know that block randomization can ensure equal number of groups at any given point of time in a trial. Okay, so the answer is block randomization. Next question, which of the following is not a proper method of randomization? Everyone with odd number of date of birth gets treatment, even number gets placebo. The allocation takes place even before examining a patient. A random list generated by computer is used to assign groups. Every 6 patients after recruitment are assigned according to a sequence. A new sequence is generated for the next 6. 124 cities where a large RCT is planned are randomly allocated, and every city falling under one arm receives the same intervention or placebo. All of the above are incomplete randomization methods. So what is the correct answer? Now this is quasi-randomization. A is quasi because you're using date of birth. B is a simple random procedure. C is a block randomization procedure, and D is a cluster random procedure. So there are 4 procedures here, and which one is the inadequate method? And the not proper method is a quasi-random procedure, and that is A. You're using date of birth, so this is a quasi-random procedure. Next, to determine the efficacy of exposure therapy or cognitive restructuring relative to wait list control group in preventing chronic PTSD in those with acute stress reaction, a trial was designed. Participants were randomly allocated to one of 3 treatment conditions. Randomization was conducted by a process of stratification by sex, trauma type, and acute stress disorder score. Random number system was administered by a third party in a distant center not involved in the study. In the above study, the reason for using a third party in assignment of random sequences is A. To ensure blinding, B. To ensure stratification process, C. To ensure allocation concealment, D. To ensure compliance with intervention, E. To reduce the cost of the trial. So why do we use a third party for assignment of random sequences? We want to ensure concealment of allocation. So answer is C, allocation concealment. That's the main reason for doing this kind of centralized allocations. Okay, maintaining secrecy about the status of a patient as to which arm he or she belongs once the allocation is complete. This is called blinding. Once you do the allocation, it's called blinding. Once allocation is done, people are assigned to treatment. Okay, so after that, if you preserve the integrity, it's called blinding. If you preserve the integrity of the sequence even before you allocate patients to treatment, that's called allocation concealment. Which of the following types of error is most obviously reduced by blinding in RCTs? Yeah, blinding reduces measurement bias. Okay, allocation concealment reduces selection bias. Okay, so 6th question. 100 patients are enrolled in an RCT comparing a herbal medicine with fluoxetine at 12 weeks for depression. Out of 50 who were assigned to take fluoxetine, 8 did not turn up for follow-up. Out of 50 who were assigned for herbal treatment, 12 did not complete the treatment or missing. Which of the following is the best way of reporting the results of this RCT? Report the number improved out of 42 for fluoxetine and 38 for herbal medicine. This RCT should not be reported. Report the number improved out of 50 for fluoxetine and 38 for herbal medicine. Report the number improved out of 42 for fluoxetine and 50 for herbal medicine. Report the number improved out of 50 for fluoxetine and 50 for herbal medicine. What's the right answer? So let's look at the issue of reporting numbers in a randomized controlled trial. Let's say you do a randomized controlled trial. 100 people enter each arm. You are comparing olanzapine versus placebo. 10 people drop out of each arm. If you now report the results only for 90 people who completed the study in olanzapine arm and 90 people who completed the study in the placebo arm, 90 versus 90 comparison, what you're doing is called a per protocol analysis, because you're only including people who adhered to your protocol. So this is called per protocol analysis. This is very useful if your question of interest is the biological efficacy of the drug. If your question is, does this drug have any physiological effect? Does this drug have any pathological effect? For those questions, you can use per protocol analysis. But if you're interested in the effectiveness of a drug, in other words, if you're interested in the real world usefulness of a drug, then you must report results out of all 100 people. So you have to report results out of 100 who received olanzapine and 100 who intended to receive placebo. Even though they did not take it, they intended to receive it at the beginning. So this kind of analysis where you include everybody who had the intention to take a particular treatment at the beginning of the trial in a trial analysis, this analysis is called ITT, intention to treat analysis. This is the ideal way of reporting effectiveness RCTs. This is the ideal way of reporting RCTs that are useful for clinical interpretation. Okay, because this is closer to clinical practice. In clinical practice, once you start giving a drug to a group of people, there's no guarantee that they will all take it. Some of them will not, and they will not take it for lack of efficacy reason, they may not take it for side effect reason, or they may not take it just simply because they don't like being under treatment. So there are many reasons why people don't take treatment. We don't have to go into that at this stage, but important point to keep in mind is because in real life not everybody take treatment, it is not a good idea to only compare those who complete treatment with those who don't, those who complete placebo. You have to include everybody who had the intention to take treatment in the analysis that you report. So this is called ITT, and ITT is preferred for most situations in clinical medicine. So for this question, what would you then report? Fluoxetine and placebo. You have 50 people taking assigned to fluoxetine and 50 people assigned to herbal medicine. Sorry, not placebo, herbal medicine. What would you report? You will report the results for all the 50 in each group. Okay, that's the right thing to do. So E is the right answer. This is called ITT, right? So that's the next question. If the above study reports numbers improved out of all 100 randomized, which of the following processes has been carried out? So the process that has been carried out is called ITT analysis, intention to treat analysis. In the above study, in order to calculate the possible missing values of 20 patients, the statistician uses the HAM-D score recorded at the most recent interview for the lost patients and includes them as the final score in the analysis. This approach is called mean imputation, last observation carried forward, worst case scenario, best case scenario, hot deck imputation. So what would you call this? So there are people who do not give you data. They drop out, they miss from the trial. But I'm telling you, you need to report everybody's results in order to call that as ITT and in order to make that as more real world like. So what would you do? You are facing a dilemma. You have to report on everybody, but some people are missing. You don't know what happened to them. You don't have any scores for them. So what can you do? You can do one of two things. You can either do a last observation carried forward. See, people do not all drop out on a single given day from a trial. Some people drop out on 12th day, some people drop out on 12th week, some people drop out after 8 weeks, so on and so forth. You just take the last observation that these people gave to you, the last rating scale that they completed, take the values from that rating scale, okay? Well, it should be the same rating scale that you are evaluating the study with. Take the value from that last observation and take that value as the final value. So whatever was the score of HAM-D, let's say, at 8th week, will be considered now as the score of HAM-D at the end of 6 months, in a 6 months trial. So this is called last observation being carried forward, LOCF. Okay. So LOCF is useful when you're using a rating scale for measuring an outcome. What if you use categorical cutoff points for measuring an outcome? What if you classify people into people who respond or do not respond, or people who get discharged from hospital or don't get discharged. So if you have categorical measures like that, you can use extreme case scenario as the method of dealing with missing data. You can assume everybody whose data is missing or dropped out is people who got discharged from the hospital, or you can consider everybody who is missing data as people who stayed in the hospital but refused to give data. So you can actually use either one of the two categories as the scenario, but you have to apply that for everybody universally. Okay, so you can't just pick some patients to apply extreme case and pick some patients to apply a different method of outcome analysis. So categorical measures use extreme case scenario. Extreme case scenario could be worst case scenario where every dropout is considered to be unwell, or best case scenario where every dropout is considered to be getting better. Okay, so depending on how you tilt, what protocol you set up at the beginning, you can have a best case or a worst case scenario analysis. These are two ways of dealing with missing data. There are also multiple other ways. I'm not going into details of them. There are things like bootstrap method, things like Monte Carlo simulation. There are also things like hard duck imputation, mean imputation. We're not going there today. All you need to know is between LOCF and extreme case scenario, which situation demands you to use one and which situation demands you to use the other. Categorical measures use extreme case scenario. Continuous measures like grading scales, you use LOCF. So in the above study, you have a scale that you are using to record the outcomes, HAM-D score. So you're taking the last interview from each patient and using that as the final score. This is called last observation being carried forward, LOCF, choice B. If this trial is carried out to see the biological efficacy of the new herbal medicine and not to compare its clinical effectiveness against fluoxetine, which of the following methods of analysis will be most suitable? Per protocol, last observation carried forward, mean imputation, intention to treat, sensitivity analysis. Okay, so you know the answer for this. It's per protocol analysis because this is a study of biological efficacy, not just clinical effectiveness. Okay, so with that, let's move on to the next topic, pragmatic RCT. Now, an RCT is probably one of the best forms of evidence available in clinical practice, but RCTs are not always useful. Sometimes what RCTs show does not turn out to be true in clinical practice, and what clinical practice demonstrates may not be seen in an RCT setting. So, how can we make an RCT more real-world-like? How can we make the RCT more real-world-like? You have to tune or tweak the RCT a little bit. The normal, regular, conventional RCT has to be tweaked a little bit in order to make it appear more close to the real-world practice. So this is called pragmatic RCT. Any RCT that seems close to real-world practice is called pragmatic RCT. How can you do pragmatic RCT? You can, first of all, you can stop people from being blind. You never keep people blind when you're doing treatment in your clinic. So why should you keep people blind in RCT? So stop people from being blind. That will make it more pragmatic. You do not offer excessive follow-ups. In an RCT, what happens is people are followed up more frequently than they're required to follow up, and then they need to follow up. So this creates a bit of a difficulty because you can't do that kind of intensive follow-up in real-world practice. Okay, so if you reduce the frequency of follow-up, that also makes an RCT more pragmatic. If you do ITT analysis, intention to treat analysis, that also makes an RCT more pragmatic. If you have strict inclusion-exclusion criteria, for example, in a trial of antidepressants, if you exclude everybody who drinks alcohol, then that's not representative of the population. Okay, and that's not very pragmatic. So if you have loose inclusion-exclusion criteria, loose in the sense flexible, and allow people to come into the study, then you're doing a more of a pragmatic trial. Don't give any special training for people involved in a trial. Just keep them as frontline workers, like nursing staff, and keep them as trained as your frontline workers. Don't train them more than your frontline clinical workers. So that will make it easy for that'll add to the pragmatic value of an RCT. So these are the various things you can do to make an RCT pragmatic. Remember, you don't have to do everything in order to call an RCT pragmatic. Only even if some elements are present and tried, then you can assume the RCT is trying to be more pragmatic. What are the other special types of RCT we have? We have parallel RCT, which is not a special type. It's the most common type, and you know what it is. You have two arms, and both arms receive treatment, different treatments. One may be placebo, one may be active treatment, but two treatments are given at the same time. Okay, so this is called parallel RCT. and each person gets only one exposure, either to the treatment or to the placebo. In a crossover RCT, you start with two groups, just like a parallel RCT. One group will get the treatment, one group will get the placebo. But after a period of time, you switch the groups over. So whoever got placebo first in phase 1, in phase 2, they will get active treatment. Whoever got active treatment in phase 1 will now get placebo in phase 2. So this kind of crossover makes a trial crossover RCT. The important thing about crossover RCT is you can do crossover RCT only when your treatment is reversible. If you're doing some irreversible treatments like removal of appendix, doing surgical treatment, then there's no way you can undo that and start people on a different treatment or give them placebo, because treatment is irreversible. Okay, so the treatment has to be reversible in order to do crossover RCT. Number two, there should be some reasonable washout period in which the treatment doesn't stay on the system and disappear from the system, from your body. So if you can't achieve those kind of washout periods in between the two phases, then you cannot do a crossover trial. Okay. Number three, a condition for which you do crossover trial, it should not be curable. If it's completely cured on being exposed to an experimental drug, then there's no point giving placebo to the same patients. The condition is gone already and you can't see any response. Okay, so these are some of the conditions for doing a crossover trial. It's quite a useful design. You can boost the sample size by using small number of people. You can boost the power by using a small number of people if you switch from a regular RCT to a crossover RCT. Okay, because 50 people are allocated into groups of 25 and 25 in a normal RCT. In a crossover RCT, what happens? They're initially allocated 25-25 to different groups, and then they switch over. Then you have another comparison of 25 and 25 now. So you totally have more than 50. Well, you totally have more than 25 comparisons, 50 comparisons you can make. So this increases the power of the study. So this is another strength of crossover RCT. What is N-of-1 trial? In N-of-1 trial, you have only one patient. N stands for sample size. You can have only one patient. How can you do an RCT with one patient? Yes, you can. Let's say you have a situation where you have tried every treatment on earth for treatment-resistant depression. The patient is not getting better. You've tried everything: amitriptyline, monoamine oxidase inhibitors, lithium, ECT. Everything has been tried. The patient is still resistant to treatment. You have only two choices left. One is a very new drug that was marketed only yesterday, and the other is a very old drug that has some not very likable side effects. So you have these two drugs. How can you decide which one do you choose for the next treatment? You can tell the patient, look, I don't know which is best for you. I'm going to close my eyes, which means I'm going to be blind. I want you to close your eyes as well. I want you to be blind as well. Let's ask the pharmacist to give either the new treatment or the old treatment in an alternate fashion. So first 2 weeks you receive the new treatment randomly. Next 2 weeks randomly you will receive the old treatment. And we'll have a washout period, and then again we repeat the cycle. So let's just repeat the cycles, and we'll make sure that we measure the outcome or severity of your illness after every trial is over. After 6 months or so, we would have done almost around 8 trials with treatment A and 8 trials with treatment B. We can now then stop and sit together and look at the efficacy of A or B. If you have been consistently showing improvement in mood after treatment A compared to treatment B, I will then ask you to stay on treatment A for more than 6 months, 1 year, or whatever that is appropriate. So this kind of trial where one subject is chosen, but one subject is randomly given either A or B to see which one works better, this is called N-of-1 trial. Okay, this is probably the best form of evidence that you can gather for a single particular patient, specific patient that is sitting in front of you. Every other evidence that you collect, even from meta-analysis of RCTs, very good, very large meta-analysis, every other evidence that you get is not immediately directly applicable to the patient, because that evidence is not gathered from this patient. But in an N-of-1 trial, you gather evidence from the patient directly, so it's more applicable to the patient. But the problem with N-of-1 trial is it's not generalizable to other patients. So just because your patient has treatment A working better than B, you cannot always use treatment A for other patients, because this is not a trial where a sample is drawn randomly from a population. Okay, so you can't generalize the results back to the population. You have to apply the result only for the patient on whom the trial has been conducted. This is called N-of-1. What is factorial? In the factorial RCT, let me see if I have any slides for factorial RCT. I don't. So in a factorial RCT, what happens? Let's think of an example. It's easier to understand examples. You want to compare the efficacy. You want to find out whether antidepressants work better or antipsychotics work better in patients with psychotic depression. You want to do a trial. So in this trial, you have various options. You can give a set of people. One arm could receive antidepressants only. Another arm could receive antipsychotics only. A third arm could receive both antidepressants and antipsychotics. A final arm could receive neither antidepressants nor antipsychotics, that is placebo. Okay, so you have four arms, two conditions: antidepressants and placebo, antipsychotics and placebo. Two conditions, but you have four arms. So this is 2 by 2 factorial RCT. Okay, so you have four arms. This is 2 by 2 factorial RCT. It's quite useful to understand the synergistic effect of treatments. You can use this for example, if you want to find out if antidepressants work better in combination with CBT, you can do a factorial RCT. You can evaluate antidepressants alone, CBT alone, both together versus neither of them. And this kind of comparison will tell you if a combination works better than individual treatment. So this is called factorial RCT. The problem with factorial RCT is you are divvying up a small group, 100 patients that you want for randomized controlled trial. You're divvying them up into 4 groups instead of 2. So you're losing some power in your analysis by doing a factorial RCT. You really need a large sample to properly do a factorial RCT. Let's now see some questions. Question 10. A single subject is administered placebo and active intervention in tandem under double-blind control conditions. This type of study could be called, you know the answer for this, is N of 1 trial. Question 11. Which of the following factors seen in an RCT makes it different from natural clinical practice? Strict exclusion criteria, use of placebo, frequent follow-up and attention given to patients on trial, being blind to treatment, all of the above. So the answer is yes, all of these are problems with RCT. So all of the above is the right answer. This is why we do pragmatic RCT. Which of the following conditions of causality make cohort studies better than case control studies in exploring causal association? Okay, so this question could have come earlier, but well, we can answer it now. You know the conditions of causality. What makes cohort study better than a case control study when you're exploring causal associations? Yeah, in a cohort study, you could establish temporal association between the cause and the outcome. In a case control study, you cannot have temporal association because you're not observing people over a period of time. Temporality can be established using a cohort design. So B is the correct answer. A statistician explains to you that confounders are not eliminated by randomization, but he still insists randomization is the best way of controlling confounding bias. Which of the following is a suitable explanation? Confounders can cause an effect only if they are distributed differently between study groups. Confounders can be statistically checked only in randomized samples. Confounders are identified and restricted in randomization process. Statistically checking for confounders is not necessary if adequate randomization is done. None of the above is true. So what is the answer? Confounders can cause an effect only if they are distributed differently between study groups, and you know the answer for this. So A is the right answer. With regard to pragmatic trials, A, it is essential to have modeled all the details of the intervention beforehand. The main aim is to tell us how well does a drug work. They have high external validity. They are less generalizable than explanatory trials. They have more exclusive referral criteria than explanatory trials. So what is the right answer? They have high external validity. Pragmatic trials are more generalizable because the trial itself is more like a real world practice. So you can take the results and easily apply to general clinical practice. So they have high external validity. External validity means generalizability. How easy it is to take the results of a trial and apply to the population which you serve. That's called external validity. A normal RCT, a conventional RCT, has quite poor external validity. It has very good internal validity, but it has very poor external validity. So you use a pragmatic design to improve the external validity. Remember, there is a trade-off. Whenever you improve external validity, you will also give up a little bit on internal validity. Okay, but the question was about external validity in pragmatic trials, so that was the right answer. Next question, with regard to randomization, choose the best option. It can only be performed at the level of individual patients. It guarantees that study will be free of confounders. It automatically leads to poor generalizability. Concealment of allocation of randomization refers to whether the outcome can be predicted. Non-randomized studies are less likely to be affected by confounding than randomized studies. What is true? Well, first of all, you can perform randomization at individual level as well as cluster level. So A is not correct. Okay. B. Randomization does not guarantee the study will be free of confounders. It only increases the chance that confounders are equally distributed. Still, you have to make sure the confounders are equally distributed by looking at the distribution of confounders in the two groups. This is why we do, whenever you read a paper of any randomized control trial, the first table reported in the journal article would be a table that compares the baseline properties of the two groups to make sure that they show whether any confounders are equally distributed or not. They present a table. All of those authors who do RCT, they present a table to you to show to you whether the confounders are equally distributed or not. Okay, if they are not equally distributed, despite randomization, then they have to be adjusted in statistical analysis. So that's a different procedure which we'll talk about later on in advanced statistics. Now C, so A is wrong, B is wrong as well. C, it automatically leads to poor generalizability is not correct. Randomization is not the reason why RCTs are, conventional RCTs are poorly generalizable. Okay, randomization improves generalizability because you randomly pick people from population to get into your sample. That you do to make sure your sample looks very much like your population. Okay, so randomization gets to help you with generalizability. So the problem in an RCT, problem why it is poor, it has poor external validity is not because it is a randomization procedure that is being done. It's because of other reasons that I highlighted before, like blinding being done, fixed doses being used, increased amount of follow-ups being given, strict inclusion exclusion criteria is being used. All of those things lead to poor generalizability, not randomization. So far we have removed A, B and C from the options. What about D? Concealment of allocation refers to whether outcome can be predicted. Yes, that is correct. Concealment means whether the outcome of sequence generation, outcome of randomization could be predicted or not. So for this one, right answer is D. Okay, so that's quite a lot of information for you. So what have we seen so far? We've seen randomization methods, different methods. We have seen what is allocation concealment, what is blinding. We have seen what is ITT and how to deal with missing data. We've also seen pragmatic RCT and NF1 trials in detail. I've also introduced to you what is a factorial RCT. So those are the different types of concepts we have seen so far. Okay everyone, now we're moving to qualitative research. So far we have been looking at quantitative research studies which look at things that are measurable. Now we are moving to qualitative research which looks at things that are not measurable. These are intangible things, abstract things such as values, attitudes, wishes that people have. So the common term used to describe qualitative research is social research. We use qualitative research quite a lot in psychiatry and in psychology. So the difference between quantitative and qualitative research lies in the purpose. The quantitative research is usually done to test a hypothesis, but a qualitative research is done to generate hypothesis. So the method that we use in qualitative research is inductive. We are not testing for small clues to understand something bigger. That method is called deductive, and that's what we use in quantitative research. But in qualitative, we use an inductive method. We only study a phenomena or a set of phenomena that are of interest for us in a sample, and we do not generalize from that sample to anywhere else. But in quantitative, what we do, we study a small sample and we generalize to a larger population. Okay, so in quantitative research, like case control cohort, we do deductive approach, but in qualitative research, we do inductive approach. So that is not generalizable. Okay. In qualitative research, we do purposeful sampling. We study people that we are interested in. We do not care if they represent the average or not. But in quantitative research, we study people who represent the majority, who study people who are representative of the population that we want to study. So random sampling is what we prefer in quantitative research, such as cohort study RCTs. But in qualitative, we prefer purposeful sampling. And so we are interested in studying anomalies and outliers when it comes to qualitative research. In quantitative research, we try to discard anomalies and outliers. Whenever you see a deviant case in a quantitative research, you try to explain why it is deviant, and you try to exclude them from analysis so that you capture the average. But in qualitative research, you do the otherwise. You do the opposite. You are keen to know something about the anomalies and outliers. In qualitative research, we are not studying any controlled interventions, but in qualitative research, we are not estimating any causative factors as well. So no controlled interventions, no causative estimation, no cause-effect relationship here. Only study a phenomena, try to understand what it is. That's it. You can generate a theory, you can generate a hypothesis. You're not testing the hypothesis. Okay, so you can only come up with speculative notions. You cannot test those notions in qualitative research. So let's see some questions on qualitative research. Question 1. A study was conducted to explore the process and outcomes of a program of occupational activities for patients with dementia. Data from observations, interviews with patients and staff, and field notes were analyzed to discover the opportunities and barriers to conduct an occupational program in a day hospital unit. The above study falls under which of the following study designs? Experimental, analytical, qualitative, uncontrolled trial, clinical audit. Okay, so this is a qualitative study because we are looking at process and outcomes of a program. So we are interested in the opportunities and barriers. Okay, so the phenomena of interest for us is opportunities and barriers. These are not something that you can measure. So this is qualitative research. Qualitative methods include all of the following except census survey, focus groups, participant observation, discourse analysis, semi-structured interviews. So what are the methods in qualitative research? Okay, census survey is not a qualitative method. You might remember me telling you that cross-sectional surveys, if they are done on the entire population instead of doing them on a sample, then the cross-sectional surveys would be called census surveys. Okay, so a census survey is quantitative by definition. It is not qualitative. So Q2 answer is question 2 answer is A. Census survey is not qualitative. In which of the following studies a qualitative approach is most appropriate? A comparison of the effectiveness of tetrabenazine versus reserpine in the treatment of tardive dyskinesia. Would you do a qualitative study for this? Probably not. An exploration of the role of community team coordinators in elderly community health care teams in northeast of England. Role is something that is not measurable, so probably for choice B we can do qualitative study. What about C? The survey of number of school teachers exposed to bullying. So whenever you see survey and something that tries to measure number, this is quantifiable, so this is not qualitative. Okay. D is also a survey, a national survey of doctors' knowledge of prescribing nicotine replacement therapies. So you can send a postal survey of a specific set of questions and you can actually measure. So these things are not qualitative. D is also quantitative. What about E? Multi-center pragmatic naturalistic exploration of all-cause discontinuation rates of antidepressants. So discontinuation rates are quantities. Okay. The term naturalistic should not mislead you. Don't think naturalistic is equivalent to qualitative. Okay. Don't think exploration equates to qualitative as well. Okay. So the outcome of interest is rates, which is quantity. So all of these are quantitative except B. Okay. So the answer is B. Which of the following is generally a feature of qualitative but not quantitative research? Testing hypothesis, deductive approach, purposeful sampling, controlled interventions, estimation of causative factors. Purposeful sampling is a feature of qualitative research. Everything else is a part of quantitative research. If you want to test hypothesis, you do quantitative research. If you want to deduct something, quantitative. If you want to compare interventions, quantitative. If you want to estimate causative factors, risk factors, do quantitative. Only purposeful sampling is a part of qualitative research. Question 5. In grounded theory method of qualitative research, the term theoretical saturation is used to describe which of the following? Process of testing new categories using fresh data, point at which no new categories can be developed, point at which research is stopped, process of checking validity of information using various sources of data, none of the above. So have you heard of this term grounded theory? Let's see what grounded theory is. In a qualitative research project, so let's say you're interested in collecting opinion of a group of inpatients, on trainee psychiatrists. Okay, so you want to know what do inpatients think about junior doctors working in the psychiatry inpatient unit. So let's say you collect a group of 12 patients and you ask them some questions. The first patient comes up with selected number of statements about junior doctors. So she says something like, junior doctors are very punctual, I like interacting with them, they're more available. So some ideas, some categories of themes, emerge from talking to the first patient. Then you move on to the second patient, you interview the second patient. He or she also says few things to you. And is it possible that some of those things that the first patient has said is also said by the second patient? Yes, it is. Okay, so there will be some categories that are already included by the interview from the first patient, but there are some new categories as well that will emerge from talking to the second patient. What about moving to the third patient? Again, you will have some old categories and some new categories. Fourth patient, again some old, some new. If you keep moving on like this, at some point, let's say eighth patient, you will not get any more new categories. Whatever that has to be said about junior doctors working in psychiatric wards has been already covered by the previous 7 patients. There is nothing new that comes from talking to the 8th patient. That point at which you're not getting any new categories, that's called the point of theoretical saturation. Okay, so theoretical saturation is a point at which no new categories emerge. And the way that you determine theoretical saturation point is by going back and forth between the data and the categories that emerge from the data. So you collect the data, you grind it to find categories, you go back to the data, new data again, see if something new comes back. So you keep going back and forth. This is a cyclical iterative process. This iterative cyclical process is called a grinding process, or this approach is called grounded theory approach. You are grinding the theory and you're making sure nothing more comes from it, and that point where nothing new comes is called theoretical saturation. Now, some skeptic may tell you, look, this may not be the point of theoretical saturation. If you ask few more patients, you might get something new. So how can you confirm that you have reached theoretical saturation? Okay, so mark the patient number 8. That's the point you reach theoretical saturation. But don't stop there. You take all those categories that you have collected so far on a sheet of paper. Just write down all the categories from previous 7 patients on a sheet of paper. Give those categories to the 9th patient, 10th patient, and the 11th patient, and ask them, do you think, is there anything new that you want to say apart from what's been said by other people that's given in this list? Okay, so if those patients 11, 10, 9, 10, and 11, if they say nothing new, they say, okay, this is all what we want to say as well, there is nothing new, then you have definitely reached the point of theoretical saturation at point 8, at the patient number 8. So this process of checking whether you have reached theoretical saturation or not by collecting fresh data on the basis of the previous categories, this is called theoretical sampling. So what you have reached at patient number 8 is theoretical saturation. What you did with patients 9, 10, and 11, that's called theoretical sampling. Okay, so together, all these processes together, they're called grounded theory. The whole approach is called grounded theory approach. This is what we do in qualitative research. So this question here, in grounded theory method of qualitative research, the term theoretical saturation is used to describe which of the following. The answer is B, point at which no new categories can be developed from the available data. Question 6. In which of the following research methods the clear-cut demarcation between researcher and the researched may not be so apparent? Ethnography, case series, action research, grounded theory, phenomenology. Let's see what is action research. Action research, also called participant action research or PAR. Individuals and groups, if they research their own experience, own personal experience, then the line between who is the researcher and who is the researched becomes blurry. Let's say a doctor wants to know what is the experience of other doctors. Okay, so then the boundary between subjective and objective becomes blurred. Okay, so this loss of clear-cut demarcation between researcher and the researched is called is often seen in action research. Okay, so the question, in which of the following research methods the clear-cut demarcation may not be so apparent? In action research. And action research is any research where an individual or a group study their own their own group. Okay, a doctor studying another set of doctors for the same set of experience that he or she experienced. That's called action research or participant action research. Okay, question 7. In a research interview, the interviewer does not follow any order, but frames the question on the basis of interviewee's previous response. Which of the following style is he following? Semi-structured interview, structured interview, projective interview, motivational interview, unstructured interview. So there are two types of interviews that we commonly use in qualitative research. One is unstructured, the other is semi-structured. What is unstructured? You ask a question, the patient says something, and based on what the patient says, you ask some follow-up questions. So you just have a conversation like you normally have in social settings. That's called unstructured interview. There is no time constraint. There is no constraint of categories that you want to study. You just have a normal open conversation. That's unstructured. These are very helpful to generate a lot of free-flowing ideas from patients. But the problem with unstructured interviews is uh, you cannot control them. The patients can say something completely different from what you want to observe or what you want to collect, and they're time consuming. Okay, so unstructured interviews only have limited use in the real world practice of qualitative research. We often use semi-structured interview. What is semi-structured interview? uh, well, if you have done MMSE, you will know what semi-structured interview is. When you apply MMSE, you don't actually ask a fixed set of questions verbatim. You don't read the question written on a paper. What do? You frame your own question, but you have leads. You have item areas that you have to cover when you do MMSE. So attention is one of them, orientation is one of them. You can ask a question in any way that you want, but you just have to cover those areas that are included in the scale. So this is called a semi-structured interview. A semi-structured interview is any interview where you have some leads to follow on and ask questions, but you don't really predefine the exact verbatim question that you're going to ask the patient, and you can lead the patient on based on the response to some extent, but you have to bring them back and cover the next category that is on your list. Okay, so this is semi-structured interview. Question 7. So what will be the answer for this? The interviewer does not follow any order but frames the questions on the basis of previous response. Now this is completely like a social conversation. So this is unstructured interview. A researcher organizes focus groups to explore the experience of being admitted at an intensive psychiatric care ward. All of the following will increase the usefulness of the study method except having good degree of group interaction. All members of the groups have common experience of being inpatients in the ward. More than one focus groups are used in the actual project. Each group has around 24 to 36 subjects only, having a predetermined topic to discuss at the group. Let's see what a focus group is in order to answer this question. Focus groups are one method of collecting data when you do qualitative research. If you want to interview people, you can either interview them one-to-one, just like a job interview, or you can do a group interview. The group interviews are called focus groups in qualitative research. The focus groups that we use in qualitative research are most useful if you are having a group of people who share something in common. Okay, and you should have some predetermined set of categories that you explore during the focus group. And it's not good to have a large group, because in a large group some people will remain very quiet. They will not express their opinion. And in a very small group as well, you will not have proper free flow of opinions, because small groups can get dominated by a few people. And in small groups also, the quite anxious people will just keep quiet because they are under scrutiny, under observation in small groups. So people might actually not respond properly in very small groups. So what is the ideal number? Somewhere between 6 and 10 is what you need for a focus group. Okay, and it's not a good idea to just have one focus group for the entire qualitative research study that you're doing. Have multiple focus groups. Try to collect the same category of data you want from different group of people. So in this question, everything is useful in a focus group except having good degree of group interaction is useful. Having all members of the group sharing something in common is useful, so they have something common to talk about. More than one focus group are useful. Okay, we've covered that. Each group has around 24 to 36 subjects. That is not going to be helpful. So this is an unhelpful option. So D is the right answer. Which of the following can be used to demonstrate validity of a qualitative study? Significance value derived from a primary outcome, duration of time spent on research, non-systematic methods of inquiry, exclusiveness of the research question, reflexivity in reporting results. Okay, so if you've done a qualitative research study, you published it, How can other people know that this research is a valid research? How can they check? How can they critically appraise the study that you've done, the qualitative study? Now, it doesn't matter what the significance values is. You're not going to report any p-values in a qualitative study. So this is option A is not correct. It's out of league. B, duration of time spent on research is also not relevant. It doesn't matter how long it takes for you to complete a research. That length of time is not going to determine the quality of your research. Okay, non-systematic methods of inquiry. Well, systematically doing something is much better than non-systematic options. So exclusiveness of research question. Just because you ask a question that nobody else has asked, the novelty doesn't mean your study is of good quality. Okay, novel studies are not always valid. So all these are wrong options. What about E? Reflexivity. Yes, reflexivity in reporting results. When you report the results of a qualitative study, you should practice reflexivity, and that will increase the validity. What is reflexivity? Well, reflexivity is one of the various methods of establishing validity of a qualitative research. What are the methods that we have here in this slide? Triangulation, first of all. Triangulation is comparing the results from either two or more different methods of data collection or coding, or two or more data sources. So you're doing a qualitative research, you want to collect the opinion of what inpatients think about doctors. It is not good just to compare, just to collect data only from one or two focus groups from a group of patients. You might want to do another focus group where instead of you facilitating the focus group, it could be a nurse, inpatient nurse, or it could be a social worker facilitating the meeting. And you could see if the categories that emerge in those focus groups are same as the categories that emerge from the focus group that you led. Okay, so that is a method of triangulation, comparing results from two or more different methods of data collection. You can also do one-to-one face-to-face interviews with your patients, and you can see if the categories that come from face-to-face interviews are same as the categories that come from focus groups. So that's also another method of triangulation. Triangulation is nothing but just checking it out. Okay, so if you have an option of checking things out in terms of validity of data, then you're doing triangulation. You can do triangulation. You can also do respondent validation. What is respondent validation? It's also called member checking. So let's say you've got a summary of all the categories that come from interviewing patients. So let's say you are observing 12 or 13 different themes that emerge from talking to inpatients. These are the most important themes about junior doctors. How can you know that what you've collected and what you've summarized is exactly what the patient actually meant to say? You could have understood it differently because you're a junior doctor, right? So how can you make sure that what you've summarized is the same categories or ideas that patients actually wanted to convey to you? Okay, so what do, you write down all the themes, you summarize the results, you give the results. You write the paper up and you give those results to the patients from whom you originally collected the data from. Members of your research. Give the data to members of your research. Give the analyzed, interpreted data, not just raw data. Give the interpretation that you made to these subjects who became a part of your trial, part of your qualitative research initially, and ask them to comment on that. And if all of these people who read that come and say, oh, this is exactly what we wanted to say to you, then all is well and good. Okay. If some of them object to what you have interpreted, then you have to react to that. You have to respond to that. So this whole process is called respondent validation. This is called member checking. Okay. What else can you do to establish validity of your study, of your results? Reflexivity. You need to reflect how your own position, how your own training, your background, your culture, your ethnicity, your race, religion, how do those things affect what people say to you? You got to stop and think about it, and you have to keep a journal of that throughout the process of your qualitative research. Okay, and if you then summarize those accounts and publish it along with your paper, that means your qualitative research has included an element of reflexivity, and that will make your study more valid. Okay. Finally, deviant case analysis. A good qualitative study should have attempted to find out outliers and deviant cases and included them in the analysis. If it hasn't, that means it's not capturing the extremes of opinions. Okay, so these are the various methods in which you can look for the validity of a qualitative research. If any or all of them have been carried out, then you can say the research is valid. So question here, which of the following can be used to demonstrate validity? Reflexivity in reporting results. Okay, reflexivity in reporting results will demonstrate validity of a qualitative research. And what is reflexivity? Consideration of the impact of the presence of the disease on the data, awareness of the patient as a positioned observer in research, refusing generated theory if any deviant case is noted, recognition of the researcher's preconceptions and their influence on interpretation, knowledge of the socialist theories. What is reflexivity? Recognizing researchers' own preconceptions and their influence on interpretation and analysis of the data. Okay, now moving on to secondary research. So far what we have seen, case control studies, cohort studies, qualitative research, all of these are primary research because they recruit individual patients. In each of the previous study designs, we've been recruiting individual patients to collect data. If you collect data not from individual patients but from previously completed studies, then what you're doing is called secondary research. So there are two types of secondary research. You can do a narrative review or a systematic review. Again, systematic review could either have a meta-analysis accompanying it, or you can do a systematic review without any meta-analysis. Meta-analysis is the mathematical synthesis of results from various individual studies, and I will tell you more about meta-analysis in the next few slides. So the most important element of a review or a secondary research is literature search. You have to search the literature in a methodical, comprehensive fashion if you're doing a systematic review. For a narrative review, there is no focused narrow question. The review is usually done in a broad sense, and there is no uniform criteria for selecting studies. Usually narrative reviews are done by experts, and these experts start collecting papers based on their own prior knowledge. But in a systematic review, we generally do a comprehensive literature search, which includes searching multiple databases, cross-checking list of references, writing to experts, looking at gray literature such as conference papers, and doing multiple language research search. So we can cover a wide variety of published and unpublished literature. So comprehensive literature search is very important for systematic review. So what is a meta-analysis? As I alluded to before, meta-analysis is numerical synthesis of results of multiple studies. Now it's important that the studies that you combine in a meta-analysis have methodology that is as similar as possible to other studies. So if you want to combine a group of 10 studies, it's important that all those 10 studies have used more or less similar methodology. You cannot combine apples with oranges, for example. You have to combine apple with an apple. So actual number of available studies, that does not restrict the performance of a meta-analysis. You can combine even 2 studies or 3 studies, that doesn't matter. How many studies you have doesn't matter. Whether you can perform a meta-analysis or not depends on the methodology of the studies. If all of them have been done in more or less similar fashion, then you can combine them. The most frequently meta-analyzed study design is RCTs, randomized controlled trials. Let's see some questions now. In secondary research, the unit of recruitment for the research study is individual patients, institutions, clusters distributed geographically, secondary healthcare centers, previously completed studies. So the answer is previously completed studies. You're right. Okay, so question 2. An old age psychiatrist is interested in reviewing the literature on hyponatremia related to SSRI use. He has wide clinical experience on this topic and chooses some key review papers as starting point and collates the information known to him already to provide a summary of evidence. Which research method is he following? Systematic review, qualitative research, narrative review, meta-analysis, case series. So this is an expert collecting data from previously published papers, but he's collecting them on the basis of his own prior knowledge. So this is narrative review. The study design which is most frequently combined in meta-analysis is uncontrolled trials, case-controlled studies, cohort studies, RCTs, case series. And you know the answer for this? This is RCTs. Okay, so how can we comment on the quality of a meta-analysis? How do we know a published meta-analysis is good enough? Number one, higher the number of included studies, the better the quality of meta-analysis will be. Larger the sample size of individual studies. So if you're combining 3 studies, even that 3-study meta-analysis could be a good one if each individual study included in the meta-analysis has very large sample size. Better the methodological quality of the studies, better the quality of meta-analysis will be. So this is called the GIGO principle, garbage in, garbage out. If you put rubbish papers into a meta-analysis, the results that you get would be also rubbish. So this is called GIGO principle. So better the methodological quality of studies, better the outcome of the meta-analysis would be. Now, based on the methodological quality of the studies, we could do something called weighting. Weighting is giving a numerical value to the quality of each individual study in a meta-analysis. Okay, so weighting is numerical value, attaching numerical value to quality to each individual study in a meta-analysis based on the quality. Well, it could be based on quality, it could be based on number of factors, and I will show you in the next slide what are the qualities that we usually use to do weighting. Okay, so quality of meta-analysis depends on the number of studies included, the sample size of individual studies, the way each study has been conducted, and also the similarity between the studies. The more similar the studies are that are combined, the better the quality would be. So this is the quality. This is how you decide the quality of meta-analysis. What is weighting? Weighting is attaching numerical value to each individual study. So what are the different properties or qualities of each individual study that we use in order to give the weighting value? Number one, the most commonly used parameter for weighting is sample size. Larger the sample size of individual study, we will give large weighting. Okay, precision. If the results reported in an individual study is very precise, then we will give a higher weighting for that study. External validity. So if a study is very pragmatic, you might decide to give more weight for the pragmatics trial. An externally valid trial could get more weightage. Finally, methodological quality. If a study is really well conducted, let's say a triple blind RCT, that might get more weighting than a double blind RCT. Now, this is not all hard and fast. As a researcher who is doing meta-analysis, you can set a priori, you can set before you begin the study, you can set up what are the different parameters that you're going to reward by doing weighting. Okay, so you may want to choose sample size if that's what is important for your own question, or you might want to choose pragmatic nature of a trial, external validity if that's what is important for your question. So different researchers choose different things, but the most common item chosen is sample size. Okay, so weighting refers to the level of significance attached to the outcome of individual studies considered in a meta-analysis. Which of the following factors are considered for weighting? Precision of results, sample size, methodological rigor, all of the above, none of the above. So you know the answer, all of the above. Now let's now talk about heterogeneity. Now you may remember I said one of the things that's important for meta-analysis is the 5 studies that you're trying to combine, 5 or 6 studies that you're trying to combine should all have more or less similar methodology. If they are too different from each other, then you will not be able to combine them. Now, differences can arise for various reasons. Differences among studies could come for various reasons. So let's classify those reasons into 3: clinical heterogeneity, methodological heterogeneity, and statistical heterogeneity. What is clinical heterogeneity? Differences that occur for clinical reasons. For example, patients in 2 different trials may have slightly various diagnostic constructs. For example, ICD-10 might have been used in a randomized controlled trial for olanzapine in patients with schizophrenia. ICD-10 criteria might have been used. In another trial, somebody might have used DSM-5. Same olanzapine versus placebo comparison, but DSM-5 might have been used for diagnosis of those patients. So that introduces a clinical heterogeneity. You could also have heterogeneity in severity of the disease. Variability in doses might be present. Variability in duration of treatment could be present. All of this will introduce clinical heterogeneity. Now, you cannot quantify how heterogeneous studies are in terms of clinical differences. You can only observe and describe them. You cannot quantify it. Same way, methodological heterogeneity refers to heterogeneity resulting from differences in the study methodology. One trial could be a double-blind randomized controlled trial. Other could be a single-blind randomized controlled trial. So even though both of them are RCTs and they're close enough for you to combine them in meta-analysis, there are differences in the methodology of those trials, and that will introduce methodological heterogeneity. These two heterogeneities cannot be quantified. Okay, so let's not worry about them anymore. We can only describe them and observe them. What is the quantifiable difference? The quantifiable difference among studies is called statistical heterogeneity. If you look at individual trials, let's say we are comparing olanzapine with placebo in patients with schizophrenia, and we have 21 different trials which have done the same comparison, and we're going to combine all the 21 to produce one single meta-analytical result. Okay, so the 21 studies, all of them are not going to give you the same result. Let's say the result is estimated in terms of relative risk. What is the relative risk of relapse in patients who take olanzapine compared to patients who do not take olanzapine, people who are on placebo? So you are computing RR, relative risk, from each trial, and you're combining all of them to produce one meta-analytical result. Now, if you just look at the values that you get from each trial, it'll be very apparent to you. It'll be easy to observe that each trial is going to give you a different result. One might say RR is 2.1. One might give you an RR of, 5.5. One might give you an RR of 1.9. So the actual final point estimate that you get from each trial may not be the same across different trials. Okay, that kind of heterogeneity, that kind of difference is called statistical heterogeneity. Now you can describe this, you can also measure how statistically heterogeneous different studies are. You can use tests such as chi-square test, Cochrane's Q test, I-square test. All of these tests will give you a measure of heterogeneity. Now why do we bother about heterogeneity? Why should we worry about statistical heterogeneity? When you try to do a meta-analysis, and I told you meta-analysis is nothing but combining the results of a number of other studies, you can do the combination quite easily, straightforward combination, like computing average from 21 trials, if there is no significant heterogeneity. Okay, so if there is no significant heterogeneity, all you need to do is just do an average of all the values of RR, and you will get the final pooled RR. Okay, so that kind of approach is called fixed effect analysis. If there is no heterogeneity, go on, carry on, and do a fixed effect analysis. If there is significant heterogeneity present, as established by tests such as I-square, Cochrane Q test, chi-square test, then you cannot do a fixed effect analysis. That will give you misleading results. You have to then do a random effect analysis. Okay, so random effect model assumes that each individual study is giving you a result, but it doesn't assume the effect is common among all the trials. It assumes that the truth is hidden somewhere among the 21 trials. It doesn't assume the truth is a summary of all the 21 trials. Okay, so fixed effect assumes the truth is just a summary, but random effect assumes truth is hidden somewhere. That's because there is significant heterogeneity. Okay, so random effect analysis is not very preferable because it's susceptible to publication bias, and it gives you wide confidence intervals. It doesn't give you precise small confidence intervals. That's what you want from a meta-analysis. You want to narrow down your precision to a very small minuscule range. You want to be really confident in the results that you're getting. That's why you do meta-analysis. That's why you don't just depend on a single RCT. You do a combination of them. You combine them to do meta-analysis. But unfortunately, if you use a random effect model, if you have to use a random effect model, the pooled results that you will get will not have such a precision of their confidence intervals. This is a bit of a price that you pay for having significant statistical heterogeneity. Okay, but there's no other way. If you have statistical heterogeneity, don't do fixed effect. It will be misleading. Just do random effect analysis. Okay, so this is the difference between fixed and random effect. If there is a true beneficial effect of olanzapine, and if that true effect is X, then fixed effect model assumes that individual trials, the 21 trials that we are trying to combine, all of them provide results as X1, X2, X3, so on and so forth. The true X is simply an average, simply a weighted average of all of these values. Just add X1, X2, X3, so on and so forth, and divided by number of observations. What you get will be the fixed effect result. Okay, that's the assumption behind fixed effect model. What about random effect model? It says that if true beneficial effect of olanzapine is X, then the random effect model assumes that individual studies have provided results such as A, B, M, Y, etc. They're not variations of X, they are completely different. So true X is somewhere lurking in the distribution. It is not simply an average. Okay, so that is the principle behind random effect analysis. Now what is this? This is an inverted funnel plot. Now what do you plot on the y-axis? You plot the precision of the treatment effect. Okay, so precision is either standard error, 1 by standard error, or it is just sample size could also be a measure of precision. The larger the sample size, the more precise the result will be. Okay, so one of them could be here, y-axis. We often put sample size, but you can put just precision as well, standard error as well. Okay, then you have magnitude of effect size here. Effect size is here. Effect size could be RR, OR, ARR, NNT. It could be anything that you, any final product that you get from mathematical tabulation, the 2x2 tables that you use. Any product that you get from them could be an effect size measure. So you can use that magnitude of effect size here, and you use precision or sample size on the y-axis. Okay. Okay, what is the use of a funnel plot? Funnel plot can be used to detect publication bias. Now, all the studies that you see in the bottom, these are all small studies. Small studies, there are numerous studies. Small studies are usually a large number. It's easy to do small studies. So precision goes up with sample size. If sample size goes up, studies will be more precise. Okay, so can you see only few studies have very precise results? These are large sample studies. So large sample studies on top, small sample studies on the bottom. What kind of studies don't get published? Negative studies don't get published. So if you see here, the central point, the vertical line here is the zero effect or mean effect. Usually, it's not mean effect, it's zero effect. So on this side you have studies favoring a treatment, this side you have studies not favorable to the treatment. Okay, so if small negative studies are not getting published, you will see a portion of a quarter of the funnel missing. So you will see this portion missing because small studies which show negative result will be typically missing in the literature. Okay, so you can examine a funnel plot and decide whether it is symmetric or asymmetric. And if it is asymmetric along the mean, along the zero line, then you could say there is publication bias. So this was initially proposed by Light and Pillemer, and this shows the relationship between effect size and precision. So that's what I was saying so far. Funnel plot. Funnel plot asymmetry is an indicator of publication bias. So which of the following tests should be carried out in a meta-analytical study with significant statistical heterogeneity? So you know the answer for this. If there is significant statistical heterogeneity, you will automatically choose a random effect analysis. A reviewer notes the following while undertaking a literature search to identify the effect of vitamin E on tardive dyskinesia. Many small studies are published only when they show a positive result in favor of vitamin E, but larger studies are published with both directions of results. If the reviewer constructs an inverted funnel plot, which of the following will be seen? The plot cannot be constructed due to lack of negative small studies. The plot will be asymmetrical due to absence of small negative studies. The plot will be symmetrical. The plot will be asymmetrical due to the presence of large studies in both directions of results. None of the above is correct. So you know there are large studies published in both directions, but small studies are published only if they are positive. So small negative studies are going to be missing. Okay, so that is going to make the plot asymmetrical. Choice B is correct. Plot will be asymmetrical because of the absence of small negative studies. Okay, so we've seen several things so far. We've seen what is narrative review and what are the aspects of literature search. We've seen how to determine the quality of a systematic review, quality of a meta-analysis. We talked about weighting. We also talked about random versus fixed effect analysis, publication bias, funnel plot, and heterogeneity. So next we are moving on to treatment recommendations. Treatment recommendations can be of two types. Protocols. Protocols carry a sense of strict adherence. For example, life support protocol. You have to adhere to them. If you don't, if you deviate, and if something untoward happens, you may be taken to court. But guidelines are recommendations based on evidence. Guidelines do not have this kind of strict legal sense, just like protocols. Okay, so guidelines are only there to guide you to make a decision. You're not bound by the guidelines. Okay, so for example, NICE guidelines. When was the last time you had a patient who was treated exactly 100% as what NICE guidelines recommend? Probably none of them. Okay, none of our patients get 100% treatment from NICE guidelines. So guidelines are there only for us to help us to guide our decisions. We are expected to adhere to them, but we are not bound to adhere to them. So how do we make treatment guidelines? What are the steps in making a treatment guideline, preparing a treatment guideline? Now we have to use available evidence to guide decision making, and you have to synthesize the evidence. You have to do a review, systematic review and literature search, but it's also important to incorporate values and value judgments to decide on the optimal course of action. So when you write a guideline, you have to make sure the values are incorporated, values of a organization that's going to use those guidelines, that should be incorporated. And you should also consider local circumstances, local resources when you write a guideline. There's no point writing a guideline offering a treatment that is not available in the UK. NICE guideline cannot have a treatment that is not available in the UK, so what's the point of having it in the guideline? So you have to consider the local circumstances and local resource availability. So you might have seen these kind of slides before, hierarchy of evidence. You can classify research studies, various study designs based on their quality. Can you see what goes on the bottom? Personal experience, anecdotes, expert consensus, that goes on the bottom. Okay, expert committees, personal experiences, that goes on the bottom. What goes on the top? A well-conducted systematic review of several double-blind randomized controlled trials. So if you do an RCT, and a systematic review of several RCTs, that will be very powerful, and that goes right on the top. Okay, you also have other kind of study designs coming here. So RCTs are followed by systematic reviews, followed by RCT, RCT followed by cohort, cohort followed by case control, so on and so forth. Okay, so when can you know a guideline is effective? How can you make sure a guideline is effective? A guideline is highly effective if it is developed by people who will use them. There is no point in psychiatrists preparing guidelines for psychologists or vice versa. You have to develop guidelines. You have to include people who will use them to develop a guideline. And guidelines are effective if specific educational interventions such as focused meeting, learning package with credits, etc. are used to disseminate the guidelines. So just publishing them in a paper is not going to be good enough. You have to have focused educational interventions. Patient-specific reminders are quite useful to implement the guidelines. So let's say if you have guidelines for Lewy body dementia. If every time you see a patient with Lewy body dementia, if something pops up on your screen to remind you what to do in terms of follow-up, treatment, so on and so forth, that will be very effective. Okay, so to disseminate or to make guidelines to be put into use, you need to help guidelines to be disseminated using patient-specific reminders during consultations. Okay, so let's see some questions on guidelines now. First one, the most important component in the development of a clinical guideline is consulting all stakeholders, economic factors are considered, meta-analysis of the available data, systematic development, systematic literature search. Okay, it's very important to do a proper literature search to start writing your guidelines. You can't get away without doing a good literature search. A 77-year-old man falls out of NICE guidelines to prescribe anti-dementia medications, but he can get the same medications if he lived in France or Canada under their own national guidelines. How can this be explained in terms of the process of guideline production? Stakeholders such as Alzheimer's Society were not consulted by the NICE in the UK. Different set of research evidences were appraised by the different national bodies. Inadequate appraisal of literature took place while drafting NICE guidelines in UK. Anti-dementia drugs do not work that well in UK-born patients. Guidelines are not only based on evidence, but also resource availability, values, and collective preferences. Okay, so you know the answer for this. This is the last statement. Guidelines are not entirely based on evidence. They are based on evidence as the skeleton, but the actual recommendations are based on availability of resources, values, and collective preferences. Okay, so E is the right answer. The highest place among the hierarchy of evidences is given to which of the following studies? Systematic review of several double-blind randomized controlled trials, one or more large double-blind RCTs, one or more well-conducted cohort studies, one or more well-conducted case-control studies, a dramatic uncontrolled experiment. Now, you give the highest value to systematic review of several double-blind randomized controlled trials. A new national guideline on management of Lewy body dementia has been published. An NHS trust is keen to adapt these guidelines. Which are the following ways of implementation can ensure maximum effectiveness of the guidelines? Setting up patient-specific reminders during each new assessment. Yes, that sounds like a very effective method to me. Placing a bright yellow colored placard in the local memory clinic. Pharmacy sending patient-specific feedback to clinicians citing the guidelines. Providing general feedback by auditing the effect before and after the introduction of guidelines. Setting up an ultimatum locally for using the guidelines. Okay, setting up a patient-specific reminder during each new assessment. So as soon as you start engaging with the patient, you should have some reminders telling you what to do. So if that's the case, then that'll work very well. Okay, so that finishes the section on secondary research and guidelines. Now we're moving to economic analysis. Economic analysis is a very interesting topic. It is not a type of study design. It's what you do with the data that you collect from other study designs. Okay, so mostly so far we've been focused on data that pertains to health and disease. So we were collecting rating scale data. We're looking at randomized controlled trial outcomes using rating scale data. Now, if you, instead of collecting data from clinical point of view, if you collect data from a manager's point of view, in other words, if you collect money-based data, and then what you're doing is called an economic research, economic analysis. Okay, in MRC Psych Paper B exam, this is a very important topic. Even though this is only a small topic, the number of questions that have come in the last few years from economic analysis is numerous. So make sure you understand this topic fully. Now, basically, there are 4 types of economic analysis. What are they? Number 1, cost minimization analysis. Number 2, cost effectiveness. Number 3, cost utility. Number 4, cost benefit analysis. Now, there is a variation of cost utility analysis. It's called cost consequences analysis, and I'll tell you what that is in a minute. Let's now look at the differences among these 4 types of economic analysis. So let's say you have a small problem in your hand. You're going to a supermarket and you have only 10 pounds in your pocket, and you need to buy a toothpaste or a shaving brush. Okay, so you're looking at the supermarket aisle and you see 2 brands there. One type of toothpaste costs 8 pounds and the other one costs 12 pounds. You look at them both. One is 8 pounds, the other is 12 pounds. You simply buy the one that is cheaper, 8 pounds one. And the kind of mental process that you went through is called cost minimization process. You simply compare the costs and you choose whatever is cheaper. You don't care how much whiter your teeth will get if you buy one brand of toothpaste compared to the other. You don't care how long your teeth will survive if you use one brand compared to the other. All you care is the cost. Okay, so this is called cost minimization, and this is what a lot of people do most of the time in daily decision making, financial decision making, cost minimization. Okay, so only input is compared in pounds or money value. Outputs are not compared. This is called cost minimization analysis. Okay, what is cost effectiveness? If you answer the same problem using both inputs and output measurements. So if you say, okay, so this one cost me 8 pounds, and if I use this toothpaste for 1 year, the chance of me visiting dentist is, let's say, only 1 visit. But if I use the other brand of toothpaste, the chance of me visiting dentist will be 2 times. So let me decide which one will be working out cheaper. Dentists will cost you a lot. So you have to think in your mind what's going to be the effectiveness. Okay, how long will your teeth survive if you use one brand of toothpaste compared to the other? So even though the second brand is a little costlier, it's 12 pounds, you decide to buy that because that's going to keep your teeth healthier for a longer time. Okay, and if you make such kind of decision, you're doing a cost effectiveness analysis. So cost effectiveness analysis considers both the input and the output. Input is considered in terms of money, but the output is considered in terms of some meaningful measurement. And in this teeth example, I gave you a measurement of how long the teeth survive, but in clinical situations, you can actually measure outputs in terms of clinical scales. So let's say, let's have a different example to understand. Let's say your manager has 100,000 pounds to invest in a clinic. The manager asks you, can I invest it in a treatment-resistant depression clinic, or should I invest this in a psychotherapy service? Okay, and they want you to do some maths and come back and tell them which will be a good return of investment. So you consider what will happen if 100,000 is invested on a TRD clinic, a treatment-resistant depression clinic. Let's say this clinic provides ECT, TMS, and all novel therapies, and the other clinic is a psychodynamic psychotherapy clinic. Now you study the outcome by looking at number of the amount of improvement that can happen in patients who are receiving either first type of treatment, TRD treatment, or second type of treatment, that is through psychotherapy. So you look at some data and you decide that if 100 patients receive treatment-resistant depression clinic treatment, either ECT or TMS, then the average reduction in their Hamilton depression score is around 10 points after 1 year. But you find out that in psychotherapy clinic, average reduction that happens is only 2 points over 1 year. Okay, so you come and tell that to your manager. You tell them, okay, if you invest 100,000 in a psychotherapy clinic, the return that you get would be only 2 points improvement in Hamilton depression. But if you invest the same money in ECT clinic, TRD clinic, you will get 10 points improvement. Hola. So this is really what you do in cost effectiveness analysis. Input is in money, output is in some type of scales. It need not be scales, it could be anything that is clinically meaningful. Any measure that makes sense to a clinician. It could be Hamilton depression scale, it could be things like number of days that patients stay in a hospital, because number of days people are admitted is an important output for a lot of us working in hospital setting. Okay, so anything that is meaningful clinically, that's called cost effectiveness output, cost effectiveness analysis. Okay, the third type of analysis is cost utility. Now you can have you ever seen a patient who cares about 2 points improvement in Hamilton depression or 10 points improvement in Hamilton depression? No. Patients don't care for improvement in scales. They don't even care for, most of them even not care for whether they stay in a hospital for 8 days or 9 days. All people care for is, can they get back to where they used to be? So this is the functioning. People usually care about what kind of functional achievement they can make when they go through a treatment. Can they get back to their jobs? Can they do everything that they used to do before they became unwell? Okay, so if you include inputs in money, but if you estimate outputs in terms of the utility, the usefulness, using some utility scales, for example, DALI, QALY, quality of life scales, then that kind of analysis is called cost utility analysis. So in principle, cost effectiveness and cost utility, they work similarly. You compare both inputs and outputs, but inputs are compared in terms of money and outputs are compared in terms of quality of life scales when it comes to cost utility analysis. And that's all what patients care about. They only care about quality of life. So DALI, disability adjusted life years, QALY, quality adjusted life years, QOL is quality of life. So these things are measured in cost utility analysis. Okay, good. So what is the next bit? Now you have cost benefit analysis is the fourth type. Cost benefit analysis, you measure input in money, you measure output also in money. So if I invest so much money in a particular program, what is the amount of money could I save? So the question is, how would you estimate the money value of improvement in a condition? So you could do that by asking patients how much are they willing to pay to get better from a given disease condition. So for example, if you want to calculate the money value of getting a treatment response for treatment resistant depression, so if you want to ask, then what you can do, you can actually ask patients who go through treatment for TRD. You can ask them, look, last year you had significant depression, you had TRD. This year you are out of this treatment resistant depression. How much money would you have been willing to pay to get to this state last year? And if the patient says 100,000, so that's the value of getting better from TRD, treatment resistant depression. Okay, so this way you can average the values that different people come up with, and that will give you a money value for treatment response in TRD. Same way you can quantify the money value for improvement in the scale score. So for each point improvement in Hamilton depression, how much money would people be willing to pay? Now, so that's one way of doing a cost economic analysis, and this is called cost benefit analysis. Input is in money, output, the return of investment, is also calculated in terms of money, pound values. Okay. Now there is one more thing here, cost consequences analysis. I've shown that here as as an addition to cost utility analysis. Cost consequences analysis have showed up in some exams recently. So what is cost consequences analysis? Now remember, when you give a treatment, so let's say you're giving psychotherapy, or let's say you're giving ECT, the consequences of a treatment is not always only a positive consequence or a negative consequence. There are multiple consequences. Okay, so if you treat a person with ECT, number one, they're going to get better from depression. Number two, they're going to lose some memory. Number three, they're going to have some confusion. Number four, they may have complications because of anesthesia. So there are so many things that could happen whenever you intervene, whenever you do some health procedures. So many things can happen. So far, in cost effectiveness, cost utility, I was only talking about one dimension of outcome. Effectiveness is one single scale. Utility is one dimension. How do people feel they are performing in terms of their quality of life? Okay, but cost consequences is a little multidimensional. It's a bit more than cost effectiveness and cost utility. It is multidimensional. When you do a cost consequence analysis, you put input in terms of money, but output is not measured as one single entity. You measure output in terms of many different scales, multidimensional output. You include side effects, response benefits, you include multiple different things as consequences. Why do we need to do cost consequence analysis? Why can't we just live with cost utility, cost effectiveness? Managers like to see, health managers like to see multiple outcomes that could take place whenever you intervene. So they have more data to consider. They have more options to weigh back and forth to decide whether they have to invest money on one thing or the other. Okay, so cost consequences give them the option of seeing multiple different probabilities, multiple different things that could occur when you do an intervention. So cost consequences is nothing but just a multi-dimensional measure of outcome, which includes number of scales, or it includes number of different utility measures. Okay, so it's more holistic than cost utility studies because it is not based on single dimension. This helps managers to analyze various alternatives. Okay, so now next we are moving on to different types of costs. In economic analysis, we talk about costs. There are different types of costs. One is direct cost. So whenever you do something with the health service, well, you're going to visit a doctor. Let's say you have flu and you're going to see a doctor for flu. You're going to see a GP. What are the costs in this whole process? Number one, because of flu, because you go and visit a doctor, the doctor's time has to be paid. Okay, so the salary that people pay to the doctor, the amount of space the doctor is using, the GP's rent they pay to the surgery, the drugs that are dispensed from pharmacy, all of these are direct costs. Anything that directly serves to treat, diagnose, or cure an illness. So all of them is direct cost, and this cost is generally borne by the health system. As long as you live in the NHS, as long as you live in England, Scotland, or Ireland, wherever there is a free health service, this is borne by the health system. Okay, this is called direct cost. What is indirect cost? Indirect cost is cost due to loss of productivity for the patient. For example, because you had flu, you did not go to your locum work on one day. Because you did not locum on the day, you lost a lot of money. Okay, so that is called indirect cost. Indirect cost is the cost due to loss of productivity. You can also say because you were unwell, you couldn't look after your baby that day, you couldn't look after your children, so you had to ask for some caretaker's help, and that costed you, and that is also indirect cost. So in general, within our system, within the NHS, indirect cost can be seen as the cost that is borne by the public directly, public most of the time. Okay, but direct cost is borne by the NHS itself, the health services itself. Okay, what is intangible cost? Intangible cost is the cost that's borne, the cost that is not measurable. Okay, intangible is immeasurable. What is immeasurable? Pain is immeasurable, suffering is immeasurable, social stigma is immeasurable, physical discomfort is immeasurable. So whenever people have these kind of problems, pain, suffering, social stigma, physical discomfort, you cannot put a dollar value or a pound value to those problems. So this is called abstract or felt cost, intangible cost. Now remember, economists don't care about these costs most of the time because they can't measure it, they don't care about it. They only care about direct and indirect costs. Finally, I have something called opportunity cost. What is opportunity cost? Now today you're taking this webinar, you're listening to me lecturing you. Because of that, you're not actually um, spending your time with the family, or you're not doing something else on the internet which might produce some income for you. Okay, you're not seeing patients today, and that might produce some income for you, and you're not doing it today. So the opportunity cost for you today is missing your time with the family or missing your work. Okay, so opportunity cost by definition is the second best thing that you could have done if you're not doing what you're doing right now, and the cost of that second best thing is opportunity cost. Okay, cost of losing an opportunity to attend a meeting, having a dental appointment, all of these are opportunity cost. Now remember, every action has an opportunity cost. Whatever you do, you are not doing something else, okay, at the same time. So that's an opportunity cost. So if you are a doctor today, the opportunity cost of you being a doctor is not being a lawyer or not being an accountant. I don't know what the other things you wanted to become, but you haven't become those things. That's the opportunity cost for being a doctor. Okay, so everything has an opportunity cost, and that's important. Okay, so I have something else here. Proxy economic measure. Do you remember I said you could measure outcomes as well in terms of money? So I also told you that you ask a set of patients, how much are you willing to pay to get better? So this method of estimating the money value of illness variables, this is called willingness to pay, WTP. How much people would be prepared to spend to prevent or cure a particular health state. Now, willingness to pay is a little misleading when it comes to mental health, because for alarming conditions such as cancer, stroke, myocardial infarction, people generally put more money value to get better. But for problems like anxiety, depression, even though they're very disabling and disconcerting, the money value that people put to get better from those states are not very high. So willingness to pay could be a bit misleading, but that's what we use often as a proxy economic measure. And willingness to pay can also be used with the managers. We can ask the managers, how much are you willing to invest in this service, depression service, or the ECT service? So that's called WTP, willingness to pay. Let's see some questions. First question. An old age psychiatry service in Liverpool compared the costs of running a domiciliary clinic versus running an outpatient clinic for all initial referrals over 4 years. It was concluded that over 4 years, the cost of running a domiciliary clinic was £500,000, while the cost for outpatient clinic was £579,000. What type of study is this? Now remember, are they comparing inputs? Yes, they are. 500 versus 579,000. Are they comparing outputs? No, they are not. So what kind of study is this? This is cost minimization analysis. Question 2. An RCT compared the effectiveness of using co-prescribed heroin versus sole prescription of methadone in heroin users. An associated economic analysis concluded that there was a gain of at least 0.5 QALY per patient per year of treatment, and the cost saved was around £6,000 per patient per year of treatment. What type of study is this? So you're measuring input in terms of money, pounds, output in terms of QALY. So what is this? This is a cost utility analysis. Question 3. Which of the following is an appropriate study design to compare two interventions with different clinical outcomes in terms of monetary outcomes? A. Cost utility. B. Cost benefit. C. Cost effectiveness. D. Cost consequences. E. Cost minimization. Okay, so there are two interventions. They have different clinical outcomes, but you're comparing the outcomes in terms of money, monetary outcomes. Okay, so this question highlights an important aspect of using cost benefits analysis. Let's say if you're comparing two completely different interventions for two different disorders. Let's say one is a CBT for psychosis and other is ECT for depression. You have 100,000 to invest either in the CBT service for psychosis or the ECT service for depression. Your manager asks you which one is going to give you better returns. Now, psychosis is measured using completely different scales compared to depression. So you can't use the same scale and compare for each point of improvement how much investment you have to make. So that becomes meaningless in this situation. Utility values are also different between patient with depression and patient with psychosis. So what can we do then? We cannot use cost effectiveness, cost utility. We can use cost benefits. We can convert every clinical value into money value for both psychosis group and also for the depression group. And then we can convert it and then we can use the money value to estimate how much is the return of investment. So this is called cost benefit analysis. Next question. In an attempt to study the cost of adherence versus non-adherence to treatment in depression treated at primary care centers, an investigator calculates the costs of illness in terms of the cost for hospitalization, GP visit, specialist referral, cost of medications, and cost of each day of sick leave due to depression. Which of the following among the above can be called as indirect cost? Cost of GP visits is a direct cost. Cost of hospitalization is a direct cost. Cost of specialist referral is also direct cost. Cost of sick absence is borne by the person who is suffering from the illness. So that is indirect cost. 615 adult patients were asked at baseline interviews and 6-month follow-up interviews how much they would be prepared to spend per month for a 6-month treatment that would eliminate their symptoms of depression. This measure is called the willingness to pay. How much are you willing to pay to completely get cured of a problem? Question 6. A fast-track intervention program has been introduced by the Ministry of Justice to reduce juvenile crimes. There has been no intervention available to prevent juvenile crime before this was introduced. It's estimated that when 100 students are inducted into the program at a cost of £12,000 per student, 4 juvenile crime events are reduced. The incremental cost effectiveness ratio for fast track program is given by. So this question asks you to calculate something called incremental cost effectiveness ratio. Let's see what that is. ICER, incremental cost effectiveness ratio. Now this is a very simple ratio to remember if you could understand the name clearly. Increment means difference. So your increment in salary is what's the difference in your salary this month compared to last month or the last year. So increment is difference. Incremental cost effectiveness ratio means incremental cost and incremental effectiveness are placed in a ratio form like a fraction. Okay, so incremental cost is difference in cost. Incremental effectiveness is difference in effectiveness. Okay, so you have two interventions you're comparing, A and B. Find out how much it costs to give A and how much it costs to give B. The difference will give you incremental cost. Okay, and then you have effectiveness of A and effectiveness of B measured using some scale. It could be a scale or it could be any meaningful measurement. You just subtract the two different, you find the difference between the two, subtract one from the other, and you get the incremental effectiveness. Find a ratio between the two. That gives you incremental cost effectiveness ratio. So in this question, they're telling us it costs £12,000 per student for the intervention to work. So how many people are you intervening with? You are having 100 students totally. So 12,000 into 100, 1.2 million is what you are investing in this program. Okay, if you invest 1.2 million, how many crimes are you preventing? 4 crimes. Remember, there was no control program before this, so the cost of control program should be assumed as 0, and the effect of the control program is also assumed to be 0. So if you invest 1.2 million, 4 crimes are prevented. So for each crime to be prevented, how much are you investing? Difference in cost is 1.2 million. Difference in difference in effect, which is difference in crime rate, at 4. So 1.2 million by 4 gives you 300,000. So the question number 6, the answer is 300,000 per criminal event. Okay, the next question. Dr. Hidalgo, a popular poet, comes to a clinic with significant adjustment reaction. He is worried about being a poet and not practicing medicine. He wonders how much money he has lost by not practicing medicine. Which of the following terms best suits the economic loss he might have incurred? Indirect cost, direct cost, healthcare cost, opportunity cost, intangible cost? So the answer for this is opportunity cost. This is the cost of not doing the second alternative, the second best alternative that you have in your list of things to do. Okay, so at this time I also want to introduce you something called CEAC, Cost Effectiveness Acceptability Curve. What is CEAC? It's a curve that's a plot between ICER. You know what ICER is? ICER threshold, incremental cost effectiveness ratio threshold in dollars. So this is actually the willingness to pay. How much money is your manager willing to pay, but expressed in terms of ICER? Okay, so if your manager is willing to pay 25,000 pounds or dollars for each quali improvement. So the ICR threshold here becomes per quali improvement, you have $25,000 invested. So you plot that in the x-axis. On the y-axis, you plot the probability of the intervention being cost effective. So this is usually calculated using some simulations, using bootstrapping, using simulation techniques and statistics. You calculate the probability that the intervention is becoming cost effective. Okay, so as the investment increases, what happens to the cost effectiveness? So can you see here from 0 to 5,000, if you increase the investment, it increases the effectiveness, the chance that the treatment is effective increases. And the more money that you invest, the more chances that it becomes cost effective. But after you reach a particular threshold, no matter how much more you invest, the treatment is not going to show any further benefit. So let's say you're spending $1 million or £1 million in setting up a ECT clinic. That's going to treat 40% of patients from depression, treatment-resistant patients in depression. Now, after this 1 million, how much ever you invest is not going to make any perceptible change in the health of the population. So this can be understood, the cutoff point of the investment at which no further improvement can take place in cost effectiveness, that could be studied using cost effectiveness acceptability curve, CEAC. This has sometimes come up in your exam, so please revise this before you go to the exams. So far we have looked at types of economic analysis, types of cost, opportunity cost in particular, ICER and CEAC. Now let's move on to EMIs. EMI 1, study designs. So you have several choices A to J and you have 3 questions. First question, choose one option for the questions below. To investigate the relationship between domestic abuse and PTSD, patients referred to psychiatric outpatient clinic with diagnosed PTSD were inquired about domestic abuse. A group of age and sex matched diabetic patients from medical clinic were also questioned about the domestic abuse in same manner. So what study design is this? Patients are referred to the clinic and they were inquired about domestic abuse. So you have 2 groups of patients. One is people with PTSD, the other is people with diabetes. So they don't have PTSD. They're asking and they're being asked about domestic abuse in the same way. Both groups are asked about the same exposure factor. So this is a case control study. Okay. Number 2, a carefully selected group of parents of children attending child adolescent clinic were invited to provide their views on waiting time for psychotherapy and choices of treatment offered. So when you collect things like views, opinions, what kind of study is that? That's a qualitative research study. So 2, the answer is qualitative research. 3, a survey was conducted in an unsystematic sample of ward staff at a trust. The survey set out to find the degree of satisfaction with jobs at inpatient psychiatric units. Okay, so degree survey, this is a survey and you're measuring degree of satisfaction in an unsystematic sample. You just pick some people and then give them a survey questionnaire, and whatever they rate the satisfaction as, you measure that and you infer from the survey what is the degree of overall degree of satisfaction. So this is a cross-sectional study. You're studying a cross-sectional sample of people and you're doing a survey on them. Remember, degree of satisfaction. Degree is a quantity. So you can measure satisfaction in scale between 0 and 7, like Likert scale. You can have ratings such as completely unsatisfied, somewhat satisfied, partially satisfied, very satisfied, and extremely satisfied. So that'll give you a degree between 0 and 7 or 0 and 5, and you can use it to quantify the satisfaction scores. So this is a quantitative study. So it's a cross-sectional survey. So answers are given here. Case control study for the first one, qualitative study for the second one, and it's a cross-sectional survey for the third. Next question. A very costly intervention is introduced as a control measure for multiple sclerosis, though it does not cure it. A neurology team wants to compare this treatment with placebo, but they want to recruit as few participants as possible. So you want to do an RCT because it's an intervention, so you would like to do an RCT, but you want to modify the RCT in a way you can use the same sample more than once in order to increase the power. You can do that because this treatment is not going to cure the condition, and this will allow you to recruit as few participants as possible, so you can use them twice. What kind of design is that? It's a crossover randomized control trial, crossover RCT. So the option is G. 2. A clinical researcher wants to compare whether a new drug has fewer side effects than another established drug. So you have two drugs, new one, old one. You want to compare the side effects. Just like how you use RCT to compare beneficial effects, you can also use RCT to compare side effects. In fact, whenever you compare two interventional trial, the best kind of interventional trial is a randomized control trial. So please choose parallel RCT, F. The parallel RCT is the most conventional form of RCT. Number 3, a nursing research team wishes to get patients' perspectives on the quality of the care they receive as inpatients. So what would you choose here? Number 3, quality of care. So you could use a qualitative study, H. 4, a researcher wants to evaluate 4 treatments for psychotic depression. Antidepressants alone, antipsychotics alone, antidepressants and antipsychotics together, neither. That is placebo. So you have a 2x2 model here, 2 treatments and 1 interaction. So this is a factorial RCT. So the answer is J for the last one. So the answers are given here: crossover RCT, parallel RCT, qualitative study, and factorial RCT. So that's EMI 2. Let's move to EMI 3. This is about bias. First question: an early intervention team studying association between risk behaviors such as self-harm and violence in first episode schizophrenia recruits patients from acute admission ward. So what is the problem when you recruit patients from hospital, acute admission ward? You will end up having a bias because people who end up in hospital are usually the most severe spectrum of the illness, and there are also people who exhibit risk factors such as self-harm. So if you want to study the association between risk behaviors and self-harm and violence in first episode schizophrenia, the association is going to be exaggerated when you recruit patients from hospital setting. So this bias is called Bergson's bias, and this is choice B. Number 2, in a study exploring association of bullying at school and adult depression, depressed patients report more bullying than non-depressed controls matched for age and social class. So why is this? Patients with depression usually have negative recall bias. They recall negative incidents more commonly than positive incidents in their life. So whenever you do this kind of recall based studies, when you ask people in case control designs to report something that happened in the past, that's going to be prone to recall bias. Okay, so this is recall bias. 3, in a study exploring development of schizophrenia in mothers exposed to ergot fungus contaminated dry bread, only 33 out of 78 children born to mothers enrolled initially remain in the study after 20 years. Others are lost to follow-up. So what is this? This is called dropout bias or attrition bias. This is called dropout or attrition bias. When a lot of people drop out, the validity of the study becomes questionable. Okay, so this is dropout bias. Here I have shown you a little explanation of Bergsonian bias. When hospital patients are used as cases, only the severe end is captured. So this will introduce an unfortunate bias called Bergson's bias. The answers are given here: Bergson bias, recall bias, and attrition bias. So that's the end of study designs chapter.